And then he got back with me and he was like, I have a problem with work another day. So
All right. So we're going to talk about acid base. Everybody, when they hear acid base, they want to throw up in a garbage can because it's always terrible. That's because the people who are teaching it don't know a damn thing about it, and they just pass on all the terrible stuff that they were taught on to the next generation, and then they don't know anything about it, and it's just a self-perpetuating thing. So this hopefully will be a little bit different. We will cover some stuff. I know you guys don't do a ton of transfers, right? Like not a lot of like critical care transfers. I guess you do some, but not like that's not the primary thing you do. So we're going to talk about some lab stuff just to facilitate like some understanding. So here's the deal. Um, don't don't try to write down. I hate when people, and I get this with nurses all the time, where they try to write down every single thing you say. And then they're not spending any time paying attention. They're just trying to transcribe the whole lecture, and then they don't learn a damn thing. So just pay attention to what I'm telling you. As soon as I say something that doesn't make any sense, go, what in the hell are you talking about? I have no idea what that means. And I'll re explain it. And if you do that, by the time you walk out of here, you will likely understand more about acid-base balance than most of the ER physicians, because they got the same terrible instruction you did, and they never understood it either. So we're just going to kind of go through it in a stepwise form. So like I said, don't hesitate to ask questions. If you don't know who I am, my name's Dan Rau. I'm one of the intensivists at CRH. I work nights in the ICU. I'm also the medical director at Let's, and I'm a paramedic. Spent 25 years as a paramedic in Cincinnati, retired as a battalion chief at the fire department. So I've done all this stuff, and I flew in the helicopter for a whole bunch of years. I'm old as shit, so I've done a whole bunch of stuff. So I also do podcasts with Heavy Lies the Helmet, so if you've ever listened to that podcast, I do a little something with them as well. So, so what's the whole objective here? We're going to talk about what is anion gap acidosis. So I suspect when you went to paramedic school and they talked about anion gap, that was one of those things they told you didn't know. You didn't need to know. It's kind of like if you're a fire whacker, when you took your first hydraulics or pump engineering class, the guy that was teaching you, when he pointed at gauges on the pump panel and said, oh, you don't need to know about that. What that means is he didn't know anything about it, so he couldn't really teach you about it. So what he did is just told you don't need to know that. So hopefully you're going to know about all this stuff when we get finished. So we're going to talk about how to do the Henderson-Hasselbalch equation and the Winner's formula in your head. It is much simpler than it sounds. It really is all very simple, like very simple. Complicated stuff is trying to figure out how to get a ceiling fan mounted in your bedroom that doesn't wobble on high. That's complicated shit. Acid-base stuff is very simple. We're going to talk about lots of complex equations, how to identify the presence of a third hidden metabolic disorder. So when you look at a blood gas, you can have, in one patient, you can have respiratory acidosis, metabolic alkalosis, and metabolic acidosis all at the same time, in the same patient at the same time. Now, that doesn't make you want to throw up the thought of how that can all come together. I don't know what will, but you can have those same things going on. So we're going to talk about how exactly that can happen. And generally speaking, we're going to make you a badass who understands things that nobody else does, which is really the objective here. So we're going to do this through a complex series of calculations and biomedical concepts. Not really, that's tongue-in-cheek. So what we're really going to do is just talk about how to understand basic acid-base pathophysiology. So how, as a rule, I mean, when you went through paramedic school, everybody talked a little bit about blood gases, right? How to interpret blood gases. No, yes. So this is going to be that audience participation part. So here's how this is going to work. I'm going to ask you questions, then you're going to respond. So if you don't, I will then categorically pick you out and put you on Front Street and then stare at you until you give me an answer, right? So the guys in the front get the opportunity to provide the guttural sounds. So when I ask like the class a question, I'm going to look for some comprehension. So I'm going to be like, you got that? And I'll look at one of the guys in the front and I'm going to need some kind of an ugh or something. I used to do this when I did fire training at the fire department. Same thing. You'd pick out at one of the guys from the truck company in the front, and when you'd look at them, they'd just make some kind of a grunt, and that would let me know that they're like following along, right? So, on a 1 to 10, where would you say your understanding of basic ABG interpretation is? 1 meaning, what does ABG stand for? 10 meaning, got it, I could do it in my sleep. 2.7. 2.7, all right. Are you guys in the back higher than 2.7 or lower than 2.7?
We're on live, I'm gonna say 5.
All right. The first question is, are they engine guys or truck guys, right?
They're parked up right.
All right.
They truck.
All right. Good.
Body by Mag, brain by Mattel.
Right. Right. So we used to, at the last station I retired from, we had a dog. And this has nothing to do with acid-base. It's a story that entertains me. So we had a dog, and we had this multi-use structure that wasn't really meant for permanent inhabitants, but found its way to permanent inhabitants. And we always got calls over there for all kinds of stupid shit, like all the time. And it was never a fire. It was always some, EMS stuff. And like one of my last shifts, somebody set the damn thing on fire, and it ended up going to like 3 alarms. And they were joking at those guys because it was a retirement house. That's why I was there. And we said to the captain on the truck company, we said, when did you realize that was a working fire? He said, when the door cleared the dog's ass, meaning that the dog was out front. When the door got high enough that it was above the dog's ass, they knew it was going to 3 alarms. So just, I don't really know what that had to do with acid base, but it was entertaining. So that's the most important thing when you work nights the night before, is I have to entertain myself. Unfortunately, some of that will be at your expense, but it's a cost of doing business. So, all right. So as a brief review, remember that if the pH and the PCO2 go in opposite directions, it is a primary respiratory problem. All right. And if the pH and the bicarb go in the same direction, it's a metabolic problem. And it really is that simple to understand blood gases. All right. So if you're looking at blood gas and it's respiratory acidosis, the pH will be, this is the cost participation part. All right, so the pH will be down, right? It'll be low, right? All right, the PCO2 will be up, and the bicarb, and for nobody gives a shit because it doesn't apply, right? So respiratory, pH, PCO2 go in opposite directions. So if it's metabolic, they go in the same direction. The pH and the bicarb go in the same direction. So metabolic acidosis, pH goes down. The PCO2, nobody gives a damn because it's metabolic. And the bicarb goes, let's try this again. So if it goes down because they go in the same direction, right? Metabolic process, pH, bicarb go in the same direction. Respiratory process, the pH and the PCO2 go in opposite directions. All right, so respiratory alkalosis, the pH will go up. The PCO2 will go down, and the bicarb, nobody cares, right? Doesn't apply. Metabolic alkalosis, pH goes up. PCO2, nobody cares. Bicarb goes up. That is all you need to know for basic ABG interpretation. And the easiest way to do that is when you look at a blood gas, you just use arrows. And it's really that simple. pH, up, down, PCO2, up, down, bicarb, up, down. And then you know what the primary process is. The primary process is called the primary process because it drives the pH. So if the pH is low, the primary process is an acidosis. The pH is up, the primary process is an alkalosis, all right? Very simple. That's my goal. The complexity has always got to be simple, because if it's not simple, I won't understand it. The goal is for when you finish, when you took blood gas, or when you took acid base in paramedic school, there were all these crazy formulas like this. And if that doesn't make you feel like this, I don't know what will, right? Anytime you have that much math in something, it's a terrible idea. So I spent 10 years, when I started the fire department in Cincinnati, I decided there had to be life beyond being a fire whacker. So I went to the police academy, and I thought I'd be a cop. So I went to the police academy and I did accident reconstruction, and I realized that being a fireman is a much better gig than being a cop could ever be. We would always have, we'd be in the recliners, which is what we try to do most of the time. And the cops would come in, and their first thing would be when they'd see us in the recliners, be like, oh, it must be nice. Must be nice to be a fireman. We'd always tell them, a few points higher on that civil service exam, you guys could have been firemen, but you didn't get a high enough score, so you're cops. So, but the point is that when we went through accident reconstruction, there was like 10 charts that looked like that on the first day of class. And when they flipped I went to Northwestern, and they flipped up the first chart that looked like this. There were 3 guys in the back of the room, just gathered their books and just walked out because they realized that they wanted no part of that, right? So we're going to have no part of stuff like this for the entire acid-base thing. It's going to be very simple stuff, right? So I think acid-base is really one of the most misunderstood concepts in modern civilization. Well, almost one of the most misunderstood. That's probably the most misunderstood, but nonetheless. So it's probably the second most misunderstood concept. So let's start with a case, and let's talk about why it's important to know this stuff, all right? Everybody likes a good case. So this is a flight crew case, but it works for anybody that does transfers. You get called to transport a 24-year-old male from a rural podunk hospital back to a tertiary care center with a diagnosis of DKA. So podunk has multiple definitions. From the Webster's Dictionary, it's the name of a tribe that inhabits an area near Hartford, Connecticut, or a swampy place. Could be a small, unimportant town, or my favorite urban dictionary definition is a piece of shit redneck small town. So I am an expert in podunk towns because I live in one. I live in Franklin County, which is over near Cincinnati, and this is the central business district in Cedar Grove in the town that I live. There's a Cedar Grove Tavern on the left, and there is, well, that's it. So it is literally in the middle of nowhere. So I am an expert on podunk towns. So the patient in this hospital is a non-compliant type 1 diabetic who's been regulating his blood sugar with the new long-acting insulin that's actually better than Lantus. I get lots of people that you guys bring in the ICU, so I know you're familiar with this new insulin. It's called methamphetamine. So they use that instead of Lantus, right? So it is wildly successful, but it does not do much for the blood sugar. So on his arrival at the outside hospital 30 minutes ago, he was responsive to loud verbal stimulus. Those are his vital signs. All right, 108 over 56, heart rate of 144, respiratory rate of 32, and his temp's 37.1. All right, so the easiest way to make the diagnosis of DKA in the field is you get to somebody's house, tell you they're diabetic, you check their finger stick and it says high, right? So you know it's depending on your glucometer, it's higher than 500, higher than 600. Just because their blood sugar is 500 or 600 doesn't mean they're in DKA. At least half those people are just going to be simple hyperglycemia because they use methamphetamine instead of insulin to regulate their blood sugar, right? So they just have terrible blood sugar control and their blood sugar is high. So what you do next is you put them on waveform capnography. Put them on waveform capnography, and their end-tidal CO2 is 15 or 10. You just made the diagnosis. They're in DKA, right? So the next thing you do immediately is give them at least a liter of fluid, right? Because everybody that's in DKA gets a liter of fluid. Please tell me you have something besides battery acid.
We have LR.
Okay, yeah. So this is the person that you give LR to, right? Not. Do you carry normal saline too?
Yeah.
And what's the point of that? Just
More acidotic.
yeah, right. So yeah, so the indication for normal saline is well nothing. So LR for everything, right? So so that's somebody you give a liter of LR to just empirically. Okay, so those are his vital signs. You know, just from looking at those vital signs, that he is probably volume depleted, right? That's why he's so tachycardic, and he's likely also acidotic, because what in the vital signs tells you he's probably acidotic?
The nasal capno reading of 50.
The nasal capnography, but out of those vital signs. His respiratory rate, right? He's breathing like a freight train trying to get rid of that CO2 to compensate for his metabolic acidosis, right? Okay. So then you look at the labs. If you've ever seen that fishbone chart, there's a very simple way to understand what that fishbone chart represents, but we'll come back to that. So his sodium's 122, his potassium's 6.5, his chloride's 88, his bicarb's 5, so he's obviously got a metabolic acidosis. His BUN is 50, his creatinine is 2.6, and his blood sugar is almost 700. All right. Then you look at his blood gas. His pH is 7.0, CO2 is 30, and his PO2 is 94. The bicarb that you care about is this one. The bicarb on the blood gas is a calculated value. It's just like the hematocrit on the CBC. Nobody gives a shit about the hematocrit because it's calculated. It's based off of the hemoglobin. So the hemoglobin is what matters because that's a real number. In the blood gas, the bicarb doesn't matter because it's calculated. All right? So, but you know that the bicarb is 5. So what's your interpretation of this blood gas? He has a primary... Right, he's acidotic. Is it metabolic or respiratory? It's metabolic because the pH is down and the bicarb is down, right? Okay. So he has a primary metabolic acidosis. His PCO2 is low, so he has a secondary respiratory alkalosis. Does that make sense? And that's how you say it. So all that stuff that they taught you about compensated, partially compensated, throw all that shit out the window. That's 30-year-old medicine, right? Whether or not it's compensated is right here. Is he well compensated? No, his pH is 7, right? So he has a primary metabolic acidosis and a secondary respiratory alkalosis. If the primary disorder is metabolic, the compensation will always be respiratory. If the primary problem is respiratory, the compensation will always be metabolic. Because if your problem is respiratory, your respiratory system's already failing, it can't compensate for itself. The metabolic system has to kick in. Likewise, if the primary problem is metabolic, the compensation's got to be respiratory. All right, and we'll do a whole bunch of problems where we do that. But so this guy is SAS. That's sick as shit, right? All right. So this is sort of a graphic representation. The polar bear is gaining on him as he's coming around the corner, right? Very sick. So let's talk about the first complex biochemistry concept, and that is understanding this. All right. So how this works, when you look at the fishbone chart, the cations have a little positive sign. They are in the first column, sodium and potassium. The anions are the negatively charged ions, and they are in the second column. The renal function is in the third column, and then the sugar's on the end because there's no place else to put it. All right. Cations are positive. The primary cations are sodium and potassium. Anions are negative. The primary anions are chloride and CO2. All the time, every day, no matter what, they will always equal out. In your body, the amount of positively charged ions and the amount of negatively charged ions will always be exactly the same. And your body will kill you to achieve electrical neutrality. You will always have electrical neutrality. And that's how people develop these complex metabolic disorders, is their body rearranges everything else to make sure that the cations and the anions are equal. So they will always be equal. And to achieve electrical neutrality, your body will induce changes in the pH to achieve that neutrality. And if that means your pH has to go to 6.5 and you're going to die, then that's just the way it is, because your body will ensure that the positively charged ions and the negatively charged ions are equal. So that's important. That's complex formula number 1. They'll always be equal. What's supposed to happen when I look at you in the front?
Oh, yeah.
Some kind of, remember the grunt? All right. All right. So how do we calculate the anion gap? If I just told you that the positively charged ions and the negatively charged ions must be equal, then how in the hell can you have an anion gap? So the gap implies that there is normally a difference between the positively charged ions and the negatively charged ions, right? Yeah, okay, all right. Thank you. I work for tips, for God's sake. All right, so in the interest of simplicity, to calculate the anion gap, all you have to do, we leave the potassium out, so you just take the sodium, and then you subtract the sum of the chloride and the bicarb. That's it. That gives you the anion gap. So you add the chloride and the CO2, or the chloride and the bicarb together, and then you subtract the sodium from it. If it's 15 or less, you're done. So the higher the gap, the more significant the acidosis. So there are people in DKA that come through the ER, they have an anion gap of 45 or 48. They have a much more significant metabolic acidosis than somebody that has a gap of 20 or 18. So let's talk about how can this gap be possible if the positives and the negatives always have to be equal, all right? So the gap identifies the difference. So the reason that there is a gap is back when we came up with this concept, there were things that we couldn't measure because we didn't have the laboratory sophistication to do it. And those things that we couldn't measure were albumin, keto acids, and lactate. So because we couldn't measure those quantitatively, we just calculated in what those should be if they're normal, and then that was the gap. So you took the sum of what the keto acids were, what the lactate was, and what albumin was. You added those three together in theory, and then that was about 15, which then explained the gap. We can measure those things now. So we can identify what fills the gap, so to speak, and that's what makes the anion gap. So needless to say, if your lactate is elevated, if you have keto acids, or your albumin is elevated, you will have a wide gap metabolic acidosis. Okay? So here is the normal blood, or a normal set of lab values. The sodium's 140, bicarb's 25, the chloride is 105. 25 plus 105 is 130, sodium's 140, the gap is 10. They do not have a wide gap metabolic acidosis because it would require the gap be above 15, right? So they have a normal gap, no wide gap metabolic acidosis. That's the simple equation. It's really that simple. So we just talked about this. Why is there a gap? Because in that gap is albumin, lactate, and keto acids. So if they're in DKA, they'll have a wide gap acidosis. If they have an elevated lactate, they will have a wide gap acidosis. If they have an elevated albumin, they'll have a wide gap acidosis. So let's talk about lactate for a minute. Number one, it's lactate, not lactic acid. The whole world calls it lactic acid. The damn lab calls it lactic acid. It's not lactic acid, it's lactate. Number one. Number two, lactate is not a marker of sepsis. I know that CMS and all the hospital people would lead you to believe that there's some correlation between lactate and sepsis. And while there is a correlation, elevated lactate does not mean they're septic. An elevated lactate means a number of things. Number one, it can mean they are in shock. If you are in cardiogenic shock, your lactate's elevated. If you're in septic shock, your lactate's elevated. If you're in hypovolemic shock, your lactate's elevated. Any type of shock results in an elevated lactate because there's hypoxia at the tissue level. So that's what causes, it's one of the things that causes the lactate to be elevated. If we got a guy that y'all brought in yesterday that had a bunch of seizures. When he got to the ER, his lactate was 35 because he was seasoned. He had hypoxia at the tissue level that drove his lactate up. If you have a COPD that's profoundly hypoxic, has sats in the 60s when you get there, his lactate's going to be elevated. Those are all things that make your lactate go up. If you have somebody who gets epinephrine, is on an epi drip, or gets push dose epi, their lactate's going to go up. That will drive your lactate up. So all of those things can cause elevated lactate. A whole bunch of things can cause your lactate to be elevated. It's not just sepsis.
If you had I don't want to say minor, but let's say you had a pretty good lactate increase, but your primary increase was from your keto, could you, like let's say you had a respiratory issue, you had known like you struggle with respiratory issues, but then you're also diabetic type 2, you get into your DKA, but you're technically, you only have like blood sugar of 250, but because you're higher lactate, even though you have a lower blood sugar, you're still starting to make you push off ketones and increase your ketones. Because that's what we had. I had one the other day, the blood sugar was only 250, but her keto acids were really high and her lactate was high both. But the ketones were higher than the lactate.
Yeah, so if you have somebody that's got a pretty significantly elevated lactate and they have a bunch of keto acids, then what that tells you is they're probably intracellularly significantly dehydrated. And if you volume replete them, their lactate will correct pretty quickly. And their keto acids is the same. So that's the secret to curing DKA is volume, volume, volume. It's not, while the insulin plays some role, volume is far more important than the insulin in the initial stages. You've got to rehydrate them because that redistributes all of those intracellular fluids. All right, so we're back to this guy. Sodium's 140, his gap's 10, right? 25 and 105 is 130, minus 140 is 10. So now this guy, for instance, a weak acid is introduced. He starts to become acidotic. That dissociates into hydrogen and albumin. All right? And as the albumin has nowhere to go, so it adds to the hydrogen, which is buffered by the bicarb. This is as complicated as this gets. I want you to think about it like this. In your body, there's a little guy that sits on your kidneys with a fishing pole and a piece of litmus paper. And he's checking the blood all the time. And he's got 25 buckets of bicarb sitting behind him. And he's just dipping his little pole. Normally he's on the hazmat unit, so he doesn't really do anything else but just sits there and waits for something that's never going to happen. So he just keeps dipping his litmus paper in the blood. And he pulls it out, and he's like, oh, it's acidotic. Takes a bucket of bicarb and dumps it in the blood. Now he's got 24 buckets of bicarb. He keeps dipping. After about the third or fourth time he dips, no change in the acid. Takes another bucket of bicarb, dumps it in. He's trying to neutralize the blood. While he's doing that, the amount of bicarb that he has available to him continues to go down, right? That's why the bicarb is lower in people who are acidotic, because they're using it up to try to buffer the blood, right? So he just keeps dumping that bicarb into the blood. So he starts with 25 buckets, which is the kind of the normal bicarb, right? So as his bicarb, so if you look at, and this is him, and now the acid gets deposited, right? Sodium stays the same, the bicarb goes down by 10, the anion gap goes up by 10. So it's linear. The bicarb goes down by 10, the anion gap goes up by 10, right? The calculation, 105 plus 15 is 120, minus 140, the gap is now 20. He now has an anion gap metabolic acidosis. Yeah, okay, all right. That really is as complicated as this gets. So for every one that the bicarb goes down, the gap should go up by 1. It should be linear. At the end, we'll talk about when that doesn't happen, but that's what should happen. All right, so what is, this is a front row question. What is the anion gap in this patient? 22. Pretty simple. Second row. Second row. You can use an abacus, a crayon, whatever. What's 98 in, tell me your name. Brittany. It's my daughter's name. That'll be easy to remember. Brittany, what is the anion gap? It's 35. That's right.
He's a school teacher too.
Ah, very nice. All right, break out the abacus. Right. All right, 35. All right. Third row, we're getting to the fire whackers now. Now we're in trouble. What's the, say again? 12. That's right, 12. So there is not a wide gap metabolic acidosis. That's normal, right? Okay. There are 2 types of acidosis: wide gap metabolic acidosis and non-gap. So you can be acidotic and have a normal anion gap. Yeah. All right, and we're going to talk about how that happens. So the most common is wide gap metabolic acidosis. WGMA, wide gap metabolic acidosis, which is what we've been talking about. There is a mnemonic for that you got to know, because there's no way you're going to fix it if you don't know what caused it. All right? So wide gap metabolic acidosis is mud piles, methanol. Somebody drinks methanol, bad alcohol. That can cause a wide gap metabolic acidosis. Uremia, which is renal failure. Your kidneys are failing. That causes the wide gap metabolic acidosis. DKA causes wide gap metabolic acidosis. Peraldehyde, don't worry about that. It's a medicine we used 50 years ago, but it would be mud piles without it, so they just left it in there. All right, doesn't apply. You don't need to know it. It never happens. Iron, people who overdose on iron, not iron like iron, but like for iron deficiency anemia, or isoionazide. Isoionazide is a TB medicine. Very rare. You're almost never going to see it, but it is one of the causes of wide gap metabolic acidosis. Lactate, ethylene glycol, antifreeze. All right, those things can cause a wide gap metabolic acidosis. And the last one, salicylates or sepsis. Somebody overdoses on aspirin or is septic. That can also cause a wide gap metabolic acidosis. So if you have someone who has a wide gap metabolic acidosis, it will be from one of these causes. The most common being DKA or uremia, renal failure, DKA, or lactate. 80+% of the time, you have somebody who has a wide gap metabolic acidosis, that's going to be the cause. They're going to be in renal failure, they're going to have an elevated lactate, or they're going to be in DKA. Those are the primary causes. All right. Less critical to you guys, but in the ICU, as soon as somebody comes in and has a wide gap metabolic acidosis, the next thing I have to do is calculate an osmolar gap. Osmolar gap tells me if they have a toxic alcohol ingestion. That is above the level, it's not something you have to do in the 911 environment. So this is just an extra slide, don't think too much about it. So Wide gap metabolic acidosis, there's a mnemonic. There is also a mnemonic for non-gap acidosis. The non-gap acidosis is somebody that has a pH of like 7.1, but their gap is normal. So you're like, well, they're acidotic, but they don't have a wide gap acidosis. They have a non-gap acidosis. The mnemonic for that is hard up. And those causes are hyperchloremia. Somebody gave them a shit ton of normal saline. And that's what happened. So we have people in the ER. And who gets normal saline in the ER? The answer is everyone, right? So you have somebody comes in that is dry and they give them 2 liters of normal saline. And then we find out they're in DKA. So what happens is we've rehydrated them, but we gave them something with a ton of chloride, which is acid bearing. So now what happens is we just transfer their wide gap acidosis to a non-gap acidosis. So what happens is their gap closes because they were rehydrated, but their pH doesn't change because we just switched up the kind of acidosis they have. That's why giving normal saline to people who are acidotic isn't really helpful. Okay, so hyperchloremia is the most common cause. Addison's or this kind of diuretic Diamox can cause it. RTA, which is a more complicated type of renal failure, you don't need to know that. Diarrhea can also cause it. Somebody that's shitting through a screen door. If they have really bad diarrhea, what happens is they're losing their GI acid, or they're concentrating their GI acids and because they're losing all their fluid, and they have a non-gap acidosis. It just makes them acidotic. Ureteral diversion and pancreatitis. So there are other causes of non-gap acidosis, but what you really need to know is hyperchloremia and diarrhea are the 2 most common causes. Okay, so that's the question you always have to ask yourself. Everybody always wonders why I'm such a hater of normal saline. This is why I'm a hater of normal saline. This is a liter of normal saline. Do you see that? pH? pH of 5. You don't have to be a biochemist to ask yourself, if the normal pH of the body is 7.35, why would we give IV fluid that has a pH of 5? It's not the most clever approach, right? In most patients who are healthy and have normal kidneys, they can pee out most of that chloride and they'll be okay. The problem is the people we're talking about here are people who are not healthy and who cannot pee out the chloride. And now it just makes their renal failure worse because they're trying to pee out the chloride and they can't do it, so now they're concentrating the chloride that is acidotic in their kidneys and making their renal failure worse. So that's why normal saline is not a very clever approach. So all those people that told you when you were in paramedic school that the reason we give normal saline is it's most like the body's fluid, that's why we give it. They are idiots because it's not the case at all. The body's fluid is not a pH of 5.6. Okay. So you don't have to worry about that. That's too complicated. Diarrhea. So that's what I want you to remember is that diarrhea and hyperchloremic acidosis are the most common causes of non-gap metabolic acidosis. Let's talk about another concept. Everybody's seen the bicarbonate buffer system. I know you got this in paramedic school, and this should bring a wave of nausea across you as you look at this. What this tells you is this. If you have too much hydrogen ion, which is acid, and you add bicarb to it, you create carbonic acid, water, and CO2. When we were talking about blood gases, if your CO2, if your pH is low and your CO2 is high, what's that called? Respiratory acidosis. So if you have too much CO2, that causes respiratory acidosis, right? So if you have someone who has too much hydrogen ion and you give them bicarb, what do you create? CO2. So what are you doing by pushing bicarb on somebody that has a metabolic acidosis? You're making the acidosis worse. Think about that for a second. If you have somebody who has a metabolic, God bless America, if you have somebody who has a metabolic acidosis and you give them bicarb, you are converting their metabolic acidosis into a respiratory acidosis. If you've ever pushed bicarb while you have somebody on capnography, you can watch their capnography skyrocket. It goes up immediately because they are you're creating CO2. So now what happens when you have a guy in DKA with a pH of 7.1 who's in DKA because he's got pneumonia? Because we know that infection is a common cause of DKA, right? So he's got pneumonia, so he's not breathing well to start with. And you cleverly determine that you're going to give him bicarb to improve his acidosis. What is going to happen to him? He's going to increase his CO2 and you're going to make his acidosis worse. That's why bicarb is not the answer. So what are the indications for bicarb? A pH less than 7. If the pH is less than 7, they need bicarb. If the pH is not less than 7, they do not need bicarb. Giving bicarb to people empirically in cardiac arrest is as clever as giving Narcan to people in cardiac arrest.
Agreed.
No matter what the cops think, right? Number 2, well, we're talking about Narcan since this is a paramedic refresher. Everybody's taught in the police academy and unfortunately in some paramedic programs that bicarb is innocuous, that you can give bicarb and if one's good, two's better. That's why all the cops carry like 4 grams of it and they drive like maniacs at the scene so each one can give a gram. Bicarb is not innocuous. Bicarb causes ARDS. So we will often see people who now spend days, weeks on the ventilator and potentially need ECMO because they got too much Narcan pre-hospitally because it creates ARDS. It causes a weakness in the lysosomal membrane, causes fluid shifts within the alveoli, and can precipitate ARDS.
Narcan does this?
Yes.
Yes, so that's what's causing the flash pulmonary edema
Yes.
in the ERs.
Yes. Yes. So,
Yeah, take notes.
so
We're teaching the cops this, by the way.
yeah, we got to teach the cops. Stop giving the damn Narcan. I mean, a little bit goes a long way, right?
We were talking about BVMs instead.
Uh-huh.
We were talking about trading them out for BVMs
Yeah.
instead.
Yeah. So here's the problem. Most of the people that get Narcan were not dying a respiratory death. You know what we call people who are unconscious from Narcan ingestion? We call it a gift. All right, it's okay to be unconscious, right? What's not okay is to be hypoxic, right? So if they're hypoxic, then we open their airway and that will fix 70% of them right there. Just open their airway. When the snoring stops, the breathing starts, right? So just open their airway. Give them a little bit of oxygen. Maybe bag them a few times. Small doses of Narcan. I trained my paramedics over in Franklin County. We give 0.4 at a time. I just want you to have enough so you'll breathe. I don't want you to puke. I don't want you to fight. I don't want you to shit all over the cot. I don't want you to do all this crazy stuff. I just want you to breathe a little bit. And then the Narcan will wear off, or then the narcotic wears off and everybody's happy, right? Number 2, the fentanyl is not absorbed through your hands. Attention police officers across America, stop rolling around on the ground, passing out from the Narcan that's not absorbed through your hands, right? It's just not. It doesn't work like that. It'd be cool if it did, but it doesn't. Okay, that's called a panic attack. It's called a law enforcement-induced panic attack. All right, so, alas, we have digressed some. So, my point with the bicarb is that it's not free to just push bicarb and it just mysteriously corrects the acidosis. The most clever approach to giving bicarb is through a drip. That's why nephrology and in the ICU we give bicarb drips, because now the The bicarb is more slowly diffused into the tissue, which means they more slowly create the CO2, and it's much easier to blow off. When we push 2 amps of bicarb, we give them this big dump of CO2, and if they can't blow that off, then it's making their acidosis worse. So that's why it's important not to push bicarb unless their acidosis is so profound that we think they're going to die from it.
Is that why sodium bicarb is so delayed in the ACLS chart?
So let's talk about that.
Oh, boy.
Unfortunately, American Heart Association is trying to take over the world, right? So it started out, they taught CPR, right? And that was a good thing because we can all agree that CPR is helpful, right? And then they took over ACLS because, well, it's kind of like CPR. People that get CPR might need ACLS, so let's take over that. And then they got into strokes, and now they're the stroke experts. And now they're writing guidelines for pulmonary embolus because they're the PE experts. Unfortunately, the majority of their guidelines are what we call consensus guidelines. Consensus guidelines means there's a bunch of old guys on an expense account sitting around at a table drinking scotch talking about, what do you guys do where you're at? What do you guys do where you're at? What do you guys do where you're at? Well, let's do this and we'll make it a guideline. All right, let's do that. And then they write it down and publish it. It's not evidence-based necessarily. It is not anything other than the opinion of a bunch of guys. So that's what consensus guidelines means. It's the lowest form of evidence. That's why the majority of what we do in ACLS is not evidence-based. Like epinephrine. Does epinephrine improve mortality? No. No, but we do it because we've always done it. Do antiarrhythmics improve mortality? No, they don't improve mortality either. Does bicarb improve mortality? No, none of those things improve mortality. Where I write the protocols, we do not give epinephrine in traumatic arrest at all. We do not do CPR in traumatic arrest. We do not give epinephrine in cardiac arrest with shockable rhythms. If you're in VTAC and you are catecholamine driven, what is the wisdom in giving more catecholamines to someone who is catecholamine driven already? What they need is electricity. We will keep shocking the shit out of you until we get you out of that rhythm. We don't give you epinephrine. That's what evidence dictates. But alas, we're somewhat behind the evidence in a lot of areas. So, with respect to your question, most of what happens in ACLS is not really evidence-based. So we're just pulling it out of our ass because it seems like it ought to work. So there's just not good evidence for a lot of the stuff that we're doing. In traumatic arrest, for instance, we know that what will save your life in traumatic arrest is blood. If you have a tension pneumothorax, we fix that. And if you have a cardiac tamponade, we fix that. Those are the things that will allow you to survive. Everything else, you're already dead, start digging a hole. So why would we do procedures that make why would we do things that make doing the procedures that will save your life more difficult? If you've ever seen a finger thoracostomy done, you know how much more difficult it is if you're trying to do it while somebody's doing CPR. And why are we doing CPR in somebody whose heart does not have any blood in it? It does not really seem to be the most clever approach, right? What matters is opening up both sides of their chest and fixing their tension pneumothorax. Either looking at their heart with ultrasound to determine do they need a pericardiocentesis, or just empirically doing a pericardiocentesis. That's what's going to save their life. CPR on an empty heart is the ultimate form of mental masturbation, right? There is just no point to it. Like, what are we doing, right? It's the craziest thing, but we do it because we've always done it. It's nuts. All right. The world according to Dan. So And there is evidence to support that. There are some things that I will tell you that I don't have evidence for just because we don't have good evidence for everything. There's no evidence that if you jump off the roof of the helipad at Methodist that it will be bad for you. There's no evidence, there's no studies that says that's bad, but we can kind of intuitively figure that if you do that, it won't be good for you. But so the lack of evidence doesn't mean lack of efficacy, but when there isn't evidence, I think we should say that. You know, why do you do that? Just because I think it's the right thing to do. There's no evidence for that. Okay. Any questions on any of that stuff? Having said that, does anybody, like, I know you guys are still doing CPR on traumatic arrest, right?
Unfortunately.
Yeah. So does anybody work anyplace else where you do not do CPR on traumatic arrest? No? Okay. It is slowly becoming a thing. In most trauma centers across America, we're not doing, at University of Cincinnati, we're not doing compressions on traumatic arrest. Huh?
We're just exsanguinating them quicker.
Right, and if they're not, and if they're already exsanguinated, then what they need is something to fix that exsanguination, right? It's called blood, right? Blood is for bleeding, pasta, salt water is for pasta. All right, so that's the love-hate relationship with bicarb. All right, so in the presence of a wide gap metabolic acidosis, there is the rule of 15. So here's an important concept. How do you know that if they have a wide gap metabolic acidosis, how can you look at their blood gas and determine, are they adequately compensating for their wide gap metabolic acidosis? Because we know that what should happen, if you have a wide gap metabolic acidosis, you should breathe faster to try to get rid of the CO2 to compensate for the metabolic acidosis. That's what should happen. That's why when you have somebody in DKA and you put them on waveform capnography, their end tidal will be 10 or 15 because they're trying to get rid of CO2 to compensate for their metabolic acidosis. So the question is, how do we know if they're compensating adequately? Because that's important, right? If they're compensating adequately, then what we should do is get the hell out of their way and let them compensate adequately for it, right? If they're not compensating adequately, now we may be in a situation where we have to intervene. But as long as they're compensating adequately, we should let them continue to compensate adequately. All right. How we know that is if the bicarb is greater than 5 on the BMP, we add 15 to it, and that's what the PCO2 should be. That's it.
So is that just like a winner's formula shortcut?
Yeah, that's right. That's right. It's a winner's formula you can actually do without, you know, a slide rule and a laptop computer. You just add 15 to the bicarb, and you know if they're compensating adequately. And if it does, then the secondary disorder is pure compensated respiratory alkalosis. So you would say they have a primary metabolic acidosis and a secondary respiratory alkalosis. If the bicarb is 5 or less, then the PCO2 should be 15. And that's it. It's that simple. And if it is, secondary disorder is pure compensated respiratory alkalosis. If it does not, so let's say their bicarb is 7. At 15 to it, their PCO2 should be 22. Instead, it's 30. So if you didn't know this formula, you would think to yourself, well, normal PCO2 should be 35 to 45. Their PCO2 is 30. They're compensating for their metabolic acidosis. But if you know this formula, you would say, yeah, their PCO2 is 30, but it should be 22. They're not adequately compensating. And if that's the case, then they have another primary disorder. So they have a metabolic acidosis and a respiratory acidosis because their PCO2 is higher than it should be. Does that make sense? That is really important to understand that. Because it's a very different animal. If you have somebody whose PCO2 should be 15 and it's 30, they're failing compensation. They're not compensating like they should. That's a big deal, right? All right. What's the gap? Gap is 20, right. So you know immediately they have a wide gap metabolic acidosis. All right, so the gap is 20. Now you have the blood gas. What is the primary disorder? What was that?
Acidosis.
It's an acidosis. Okay, what kind?
Metabolic. No, it's respiratory. Oh, yeah, they're breathing oxygen too.
See, now we're getting all sideways. Arrows.
No, that's right.
Just go to the arrows.
And tapping out PCO2 is also down.
So pH is low.
Indicates an acidosis.
Bicarb is low. So the pH and the bicarb go in the same direction. So it's metabolic. So the primary disorder is not just a metabolic acidosis, but
With a secondary?
a wide gap metabolic acidosis.
You have to come back and teach us again next week.
All right. So, guys, in the second row, Brittany, help us out. Do you follow the wide gap metabolic acidosis? Kind of. All right, so the pH is low. If it was respiratory, the PCO2 would be high, right? But it's not. It's low. So if it's metabolic, the bicarb should be in the same direction as the, it just come off the rails. All right, you guys, when all the other numbers weren't up there, you were 100% on the anion gap. So anion gap is 20, right? All right. pH is there a whiteboard or something here we can
It's
run?
underneath it.
Huh?
If you hit the arrow up on that little white box right there, there's a whiteboard right there.
And it's slow.
Oh, boy, you ain't shitting it slow. All right.
There may still be Justin's pictures on there.
Actually, this will work out perfectly, except for these phallic symbols up here.
That was Justin's doing last week.
This actually will be better. All right. Does everybody get the gap part?
Yes.
All right. Okay. So pH is low. If it's metabolic, we'd expect the bicarb to also be low. And, well, holy shit, it is. So what is the primary disorder? Has everybody got that? Metabolic acidosis? Specifically, what kind of a metabolic acidosis? Wide gap metabolic acidosis. So primary disorder. Ugh. Okay. All right. Now, the compensation If the problem is metabolic, the compensation's got to be respiratory. So if we do the Winters formula, how do we do the Winters formula? We add 15 to the bicarb. All right, here's the bicarb. So we add 15 to that. That makes it 25. What is the PCO2? 25. So it's the compensation is adequate, right? Good. So we have a primary wide gap metabolic acidosis and a secondary respiratory alkalosis. Does that make it? You got to understand that piece. Well, no, you can't see the damn blue all the way back here. I can barely see it over there. All right, so we'll go to black the next time. All right. CO2 and bicarb are the same thing. CO2 is just bicarb dissolved in plasma. All right. So when we talk about CO2, it's the same as bicarb. Okay. Brittany, the high school teacher, come up here. I told you this would happen. The third row's next, so start thinking about who you're going to sacrifice in that third row. All right. What's so? Primary wide gap metabolic acidosis, compensatory respiratory alkalosis. All right. Brittany, what is the gap? Oh, the alarm's already going off. Okay. What's the formula? How did you come to that number?
I may have added the wrong. I added those two things.
Add those two together, and what is that? When you 110. And what's the sodium?
5.1. Oh, 27 or 127.
So what is the gap?
27.
127 minus
110.
17. Sorry.
work with me, Brittany, work
Listen,
with
I'm trying. I'm a teacher on break. I'm not used
All
to
right.
it.
Okay, so the gap is 17. So write that down where it says, what's the gap? Okay, so the gap is 17. Oh, look, you were right. Okay, it's
close.
you were close.
I got the number in the book.
What's the gap? 27. No. Ready, break. All right, so 17. Now, take me through the blood gas. Do the arrows. What's the pH?
That one's, it's down, right? Down.
Okay. What is the bicarb?
It's down also, right?
Okay, yes. And what is the PCO2?
Oh,
35 to 45 is normal.
so this one's down also.
Okay. So what is the primary disorder? pH is too low, so that makes it some kind of a,
Acidotic.
yes. And the bicarb and the pH are in the same direction.
Respiratory acidotic?
If the bicarb and the pH are in the same direction,
No idea.
okay, help her out, somebody.
You got a metabolic acidosis.
Okay.
Because it's some kind of acidosis, and if the pH and the bicarb go in the same direction, it's metabolic. Okay? So the primary disorder is what? Is the gap normal or high?
It's high.
It's high. So you have a wide gap Yes. Yes, I do. You're not done yet. All right, don't start putting the cap. That's the power of suggestion. She starts putting the cap on the marker. Right, so the primary disorder is a...
Metabolic, or wide gap metabolic.
Okay, so write that down. Primary, you can just use the abbreviated. There you go. Primary.
We're gonna do wide gap.
Okay. And so the how do we determine if the compensation's adequate? We had 15 to what?
CO2.
Okay. And that is what? 15 plus 12?
17.
15 plus 12?
I just got the 5 right. It's fine. I just got the.
So,
Listen, I teach first grade. Okay.
okay.
I'm not used to not having to.
It's not high math, right?
No, it's really not.
So 15 plus 12,
It's 27.
right, unless they've changed it. So, right, so 27. And what is the PCO2?
27.
27.
So it's adequate.
So the compensation's adequate. So the secondary disorder is respiratory. If the primary disorder is a metabolic acidosis, the compensation's got to be respiratory. What's the opposite of acidosis?
Alkalosis.
Yes, that's right. So the compensation is respiratory alkalosis. It'd be ALK though, right? Alkalosis, yes. Right. Okay.
There we go.
Unless they've changed that too, right? Right. Okay. All right. Give me that damn marker.
Here you go.
All right. You're glad to get rid of it, aren't you? All right. So that is, so the compensation is adequate, right? Why got metabolic acidosis? Compensatory respiratory alkalosis.
Really quick question, Dan.
Yes.
Are all of these things on the same page of lab values that they hand us? Because it's a 100-page packet when we do it. Critical care.
Of course.
Are they all on the same page, or do I have to go hunting for it?
These, the BMP will be all on the same page. And the blood gas, so here's the problem. In the emergency departments across America, they will often get a blood gas before they intubate them. Once they intubate them and all the high fives are exchanged for getting the tube in, then they forget the patient exists anymore and they don't get any more blood gases, right? So oftentimes you're screwed by the fact they haven't gotten a gas. If you are taking someone from here to Indy, they have got to have a blood gas before you go, because you don't know what their status is. That's why at Let's we're carrying epochs, and we do our own labs, because it's like this. You have no idea what you're treating, because yeah, venous is fine. Yeah, because in venous and arterial blood gases are the same value. The only thing different is the PO2. So, and we don't care about the PO2. All right, fire whackers in the third row. Come on up. Well, you saw that coming, I'm sure, didn't you? You were the guy sitting closest to the aisle? Yeah. Right. Okay. All right, so what's the gap? All right, gap's 10. So normal or abnormal? Normal. So there is not a wide gap metabolic acidosis. So now, okay. So now the blood gas. You can put your arrows in, yeah. Okay. So what is the primary disorder?
Metabolic acidosis.
Metabolic acidosis.
Is it normal gap?
It's called non-gap.
Oh, non-gap.
Yeah, that's right. That's exactly right. Man, you're doing fire whackers proud all over the country, huh? All right.
It's my instructor.
All right, good. So you have a non-gap metabolic acidosis. What is the mnemonic for non-gap metabolic acidosis? What's the mnemonic for wide gap?
Some pies,
Mud piles, that's right. All right, but this is non-gap, so what's the mnemonic?
hard up.
Hard up. What are the two, and last question on that, what are the two most common causes of non-gap?
Diarrhea.
Diarrhea
Something else.
and something else. Throw the man a bone. Normal saline, hyperchloremia.
Pasta water.
Okay, that's right, pasta water, that's exactly right. So now, is the compensation adequate for the metabolic acidosis?
Is it 15? Yeah, it's compensated.
So it's compensated. So it's primary non-gap metabolic acidosis, secondary respiratory.
Alkalosis.
Yes, freaking perfect.
Thank you.
All right, you're not on a truck company, are you?
I am.
What? Holy cow.
I'm undercover though.
We used to call our truck company guys the gargoyles. They always, they cut a hole in the roof and then stand around and stare down into the hole, right? Absolutely. Good job. All right. All right. Back row. We have equal parts fire whacker and EMS whackers back there. Somebody come up front.
Yeah, it's all you, Bubby. You can do this. I have faith in you.
All right.
Michael's coming.
But I missed the first part of this, so I don't know what I'm doing.
All right. Well, so what will happen is somebody's going to help you, guide him through it. What is your name on the end? Kimberly. Kimberly helped the man out since he's coming in late. So what's the gap? Do you know how to do the gap?
No.
Okay, so the gap is where you add the chloride and the CO2 and subtract it from the sodium.
The sodium is up.
36?
No, you're 10 off the wrong way, south.
So 105 and 9 is
114.
114, and 140 minus 114. Were you reaching for your phone?
No, it's
Oh, okay. I thought you needed the calculator for that one. All right. So 140 minus 114 is
26.
26. All right. So the gap's 26. The normal gap is, Kimberly?
The normal gap?
Yes.
15.
Less than 15. So you have a elevated gap, which is called a wide gap metabolic acidosis. All right. So now we go to the blood gas. So is the pH high or low?
It's low.
It's low. All right, so put an arrow next to that. All right, is the CO2 high or low?
That's low.
Okay, put an arrow next to that. And is the PCO2 high or low?
Low.
Okay, put an arrow next to that.
I'm already here at
All right, so if the pH and the PCO2 go in the same direction, or the pH and the bicarb go in the same direction, that's called metabolic acidosis. And the gap is elevated, so it's a wide gap metabolic acidosis.
Okay.
All right? So that's the primary disorder.
Okay.
All right? And then to determine if the compensation's adequate, we add 15 to the CO2,
Okay.
and that is 24.
Yeah.
What's the PCO2?
30.
So the PCO2 is higher than it should be.
Okay.
Right, it should be
26.
24
24.
because we had 15 to the CO2. If the compensation's adequate, the PCO2 should be 24. Instead, it's 30.
Okay.
So when the PCO2 is higher than it should be, what's that called?
It's higher than it should be.
Yes.
It's an alkalosis. The PCO2 is higher? I thought that was.
If it's higher, it's
Okay. If it's higher, it's an acidosis, then I'm guessing.
That's right.
Yeah.
So you have a primary wide gap metabolic acidosis and a primary respiratory.
Yep.
You already said it. Acidosis. So you have a metabolic acidosis and a respiratory acidosis, which means you have a dual disorder. You have a respiratory acidosis and a metabolic acidosis. that make sense?
Yes.
Like, which is different than if the compensation was adequate, you would have a metabolic acidosis and a respiratory alkalosis.
So if that gap is off, it's always going to be a dual disorder of respiratory acidosis and
That's right.
metabolic acidosis.
That's right.
No matter what.
All right, so that makes sense. So another question, so when you add the 15 to the CO2 kind of shortcut in the winner's formula, does that plus or minus 2 still apply? That's at the end of the winner's formula?
So it's all shades of gray, right? So if it's 1 or 2 off, then I'm like, eh. But if it's 4 or 5 off, then I'm like, man, that's probably, failure of compensation.
All right, perfect.
Okay?
I was just curious.
All right, you were at a disadvantage, but you still did all right, man. All right, thanks for playing along.
Yeah.
I'll take your marker. You'll be glad to get rid of that thing.
Yeah.
Doesn't it feel good getting that marker out of her hand, Brittany? Yeah, it's liberating. All right. Okay. You, however, have been here for the whole damn thing, so no excuses. All right.
Doesn't mean I'm paying attention.
All right, right. That's a different story. Okay, so what's the gap?
30.
30. All right, so immediately you know,
Wide gap.
yeah, wide gap metabolic acidosis, right? Okay, now take us through the blood gas. Okay.
We're so we're in acidosis,
Uh-huh.
primary wide gap metabolic acidosis, and then our gap is going to be this plus 15 would put us at 22, which is not that. So we're in with another primary of respiratory acidosis.
Well, it would be a primary respiratory acidosis if the PCO2 was too,
Too high,
but instead it's
too low.
too low. So, so what that means is you have a primary respiratory alkalosis because it's too low, and when that happens, when you see that, you have to think about a second primary disorder, and those being salicylates or sepsis. So that's that's sort of off the board for 200. That was more complicated, but you had the formula right. So absolutely.
Cheat sheet for this next time.
Yes. All right. So this is one of my favorite. What's the difference between a critical care nurse, paramedic, and a flight nurse, paramedic?
Nothing.
1,000 pictures on your Facebook like this. Makes me crazy. In front of the tail rotor. A view from my office. I had the greatest job ever. What they don't tell you is they're transporting the same patients. They just do it in a shorter amount of time, right? They're still flying non-STEMIs that the cath lab doesn't want to wait on. Most of those people get right up front. Okay, all right. Okay, so now the last sort of complicated piece of this, we're going to talk about how do you get a triple acid-base disorder. We talked about the dual disorder, right? Primary metabolic acidosis, secondary respiratory alkalosis, most commonly. So, how do you identify the presence of a triple acid-base disorder? For every 1 change in the anion gap above normal, the bicarb should change 1 in the opposite direction. We talked about that at the very beginning, right? So that tells us about the delta gap. And that will tell you how you have a third metabolic process. So, to go back to this, remember this is the normal patient right here. His gap's 10, bicarb's 25. He becomes acidotic. His bicarb drops 10. His gap goes up 10. So, all right. Who wants to do the last one? This is your chance. You do? All right, come on up. One of you two jokers up front.
Did you feel that bug?
You're getting it next time, John. Keyword last one. You got this thing.
All right.
All right. So what is the gap?
So we're gonna add our chloride and our bicarb here. So that's gonna be what, 126. Someone help me out off the top of my head.
Off the top of your head, it's written right on the board in front of you.
All right.
Okay, so the gap's 18, right?
Yep.
Okay.
So our pH is low. Our PCO2 is
35 to 45,
right,
so,
that's normal.
okay.
PO2
Nobody cares about.
cares. All right. Bicarb is also within the normal range.
Which
right?
bicarb do we look at, though? The bicarb on the BMP, right?
Yeah, right.
So it's 21.
All right. So that's low. So we're doing 22 to 26 for our values, right?
Mhm.
Okay. So we got a low bicarb, we have a low pH, so an 18 is the anion gap. It's over 15, so it's a wide gap metabolic acidosis.
And the secondary disorder is,
It's going to be,
so you had 15 to the,
we're right. So 15 to the or 15 to the bicarb. 1.5. So we're looking at what, 36?
uh-huh.
Okay, so that is not.
And the PCO2 is,
The PCO2 is 60, so, or 44, so we're off there, so it's high. So we're looking at a respiratory acidosis.
that's correct.
Okay.
So you have a primary
Metabolic
wide gap metabolic acidosis and
respiratory acidosis.
a primary respiratory acidosis, okay? So now, the normal gap is 15, the actual is 18. So the bicarb is 3 too low, right?
The bicarb is 3.
The bicarb should be 3 too low.
All right, yeah, all right, that makes sense. This should move with the bicarb, correct?
So, right, that's right.
Okay.
So the normal bicarb's 24, the actual bicarb's 21, so it should be 3 lower than normal, and in reality it is 3 lower than normal. So that's what it should be,
Right.
So there is not, so the ratio is 1 to 1, there is not a third hidden metabolic disorder.
Okay, so we just have 2 primary metabolic disorders.
That's exactly
Or
correct.
metabolic but acid-based disorders.
Yes, you have 2, that's exactly right.
Okay.
All right, so while you're there, and you're in a, so erase your stuff and go to the last one. Okay.
All right.
So what's the gap?
92 plus 20, it's going to be 112. 30.
So the
30
gap is 30.
Our pH is within normal limits, so that's fine. PCO2 looks good. PO2, no one cares. Bicarb looks fine.
Okay. So the gap is 30. Normal gap's 15. The actual gap's 30. The result's 15 too high. So the bicarb should be 15 too low.
Okay.
So the normal bicarb's 24. The actual bicarb was 20.
So is that our delta gap?
Yes.
Okay.
So it should be 15 lower than normal, but it's only 4 lower than normal.
So do we have a gap of 11? A delta gap of 11?
What, so you don't have to calculate the delta gap on the third step.
Okay.
What you need to, I want to make sure you can identify that it should be 15 lower than normal because the gap's 15.
Right.
It's only 4 lower than normal. So said another way, it's 11 too high.
Okay.
So if the bicarb is 11 too high, that's some kind of,
Acidosis, correct? Because it's, no, it'd be an alkalosis.
yes.
Okay.
So when the bicarb's too high, we call that metabolic alkalosis. So in this patient, you have the primary, you have a wide gap metabolic acidosis. You have if you had 15 to the bicarb,
Right.
so you have a respiratory alkalosis and a metabolic alkalosis.
Okay, one more time. So if we had 15 to the bicarb, we get 35, correct?
Yes.
Okay.
That's
those
what,
numbers don't
and,
match.
and the bicarb is 35. Or I'm sorry, the PCO2 is 35.
Right. Okay.
So yeah, that's where the respiratory alkalosis comes from.
Okay.
And then you come here.
I mean, I understand the gap, but I guess so this is a brand new concept to me.
Yeah,
I'm
of course.
Finding the third acid-base disorder here.
So the third acid-base disorder, the bicarb or the gap is 15.
Okay.
So the bicarb should be 15 too low.
Right. So it should be 11 essentially. The bicarb should be 11.
But it's not.
Right.
It's the bicarb's only off 4.
Right.
So it's 11 too high. So you have a third hidden metabolic alkalosis. That's why you have somebody with such a wide gap, but their pH is normal. So they had a pre-existing metabolic alkalosis that buffered that gap.
Okay. So is that why the pH isn't?
Yes,
too far
that's
away?
exactly right.
Interesting. All right. Wow. Learned something new.
Okay, we talked about that. So they had a primary anti-gap metabolic acidosis, a secondary respiratory alkalosis, and a third hidden metabolic alkalosis. So the last thing, we come back to our guy. This is our guy that buffers his diabetes with methamphetamine. So who wants to do the last one?
Tappy does.
All right.
You guys had it easy. This is the. Oh, really? We've had it easy.
I'd be a real competition.
So this is the real case.
Okay.
So this is our guy with DKA. What is the gap?
Oh, that's a great question. You got your cations, your anions, renal function, and sugar,
Uh-huh.
sodium.
Okay, and remember they're in columns for a reason.
Chloride,
Uh-huh. No, potassium.
potassium.
So chloride and the CO2. They're already in the columns above each other, man. That's why it's set up like that.
Yeah, but
So
I don't know.
88 and 5
Okay.
is 93.
I'm sorry. What was this again?
88 and 5.
No, this
Oh, that's chloride
chloride.
and CO2.
CO2. Okay. Okay, so 88, 5, 93. Minus 122, 19? No, I said 93. 29?
Well, just write 5th grade math. Just write it down on paper. 122 minus 93.
31. Yeah.
I got you.
21.
Don't look at me.
It was 31.
Can the kindergarten teacher, can you help me with the math?
31.
What were you saying?
We're doing what? 122 minus 93?
Yes.
31.
29.
I knew it was a 9. I said.
Did you really bring your phone out for
I
the?
said 29 the first time. Remember, he was like, no, it's wrong. I'm gonna have to delete this part of the YouTube.
Use AI to make it look like you got it the first time?
Yeah, no
Skip
shit.
it. Yeah, just skip this section.
Yeah, we're just gonna.
For those logging in remotely, part of me just died right now. Part of me just died. All right.
I had it right, but all of you said no.
So what did we decide? It's 29.
Decided that this is a wide gap metabolic acid.
Okay. Wide gap. So they have a wide gap metabolic acidosis. Now we want to determine is the compensation adequate.
All right, we determine that by adding 15 to that. You're at 20, right?
So if it's 5 or less,
Yeah.
it is 15.
It is 15. Okay.
So just 15. The PCO2 should be 15.
Okay, so we're compensating well.
And what is the PCO2?
It's on the left side of the board.
This one?
Way over here.
Oh shit, sorry.
Where it says PCO2, right?
CO2 is 30.
So it should be, it should be what? What should the PCO2 be? 15. So instead it's 30. So what's the second? So what's your diagnosis? It's a wide gap metabolic acidosis and
Respiratory alkalosis. Acidosis.
which one?
Alkalosis. Acidosis. If you just quit
Final
it,
answer. Final answer.
It
What
is
should the PCO2 be?
It should be 15.
And instead it is?
30.
So the PCO2 is 15 higher than it should be.
Acidosis.
Yes.
Yes.
So there's a
Dual disorder.
2 primary disorders.
Do we have a third disorder?
So that's the next question, right? So the bicarb is 5, the PCO2 is 30. The PCO2 is 30, the PCO2 should be 15, instead it's 30, right? So that's what failed compensation looks like. He's got a dual disorder. He's got a metabolic acidosis and a respiratory acidosis. So his compensation is jacked. He's not compensating.
Right.
So that's somebody you're more concerned about than somebody that is compensating, right? So now the question is there a triple acid-base disorder? The anion gap is 29. It should be the gap should be 15. So the anion gap 14 too high. So that means the bicarb should be 14 too low, right? The CO2 is 5. The CO2 should be 24. Instead, it's 19 too low. If the CO2 was too low, what is that?
CO2 is too low.
If the bicarb is too low, that's called metabolic.
Acidosis.
Yes. So that delta is 5 too low. So he has a wide gap metabolic acidosis, a respiratory acidosis, and a non-gap metabolic acidosis. Do you follow the
I
concept?
think this should stay with you in the ICU.
So now, so to some extent, you're not wrong. What's important about this is if you're doing this transfer, you pick this guy up and you should be like, holy dog shit, this guy's sick as fuck. He's got a wide gap acidosis, a non-gap acidosis, and a respiratory acidosis. He's headed for trouble. That's the point I want you to make. Whether or not you can do the calculation, know exactly how much trouble he's in, but you got to be able to look at it and go, most importantly, he's got a wide gap acidosis. Second most importantly, he's got failed compensation, which is the key part, right? He's compensating inadequately. And then third, he had a pre-existing acidosis. So what probably happened clinically, the guy's probably had diarrhea for multiple days. So he had this pre-existing metabolic acidosis. And then he goes into DKA. Now he's got a wide gap acidosis. And now he's getting tired. And he's failing respiratory compensation as well. So he's got all three types of acidosis, which is bad.
So we're going to fly him. I'm going to refuse this run.
Yeah, what you're going to do is, this is a guy who's probably going to need bicarb.
Yeah.
Yeah. All right.
He should be probably on a bicarb drip.
He should be on a bicarb drip, not a bolus. That's right.
Shouldn't we be giving all bicarb on a drip anyways?
Huh?
Shouldn't we be giving all bicarb on a drip anyways?
Yeah, probably. Almost never do I give bicarb bolus, unless I have somebody that's got like a pH 6.8 or something. Then I'll give them, 100 IV push and then put them on a drip. Okay, so it's a lot, right? But I mean, this paramedic stuff is, there's something to it, right? So, all right, so that's most of the acidosis part. You guys want to take like a little break and then let's do like, you guys want to just go throw up and then we'll talk about like other stuff. All right? So start formulating your questions. We're going to do a round robin. We'll talk about anything you want. All right.
Never talk about that again.
whoever said that.
Are you ready, Tappy?
Rolling that.
All right, so we did the acid-base stuff. I thought for the last whatever period of time, we just do kind of a round robin, just talk about stuff. Whatever, just points of clarification, stuff that you have always wondered about, stuff that doesn't make sense. I mean, I was a paramedic I graduated from paramedic school in '85. So I know where the bodies are, like I know what you don't know. So it'll be much easier if you just come out with it and we like talk about stuff like clarification. That'll keep me from like going around and like just picking people out and going, hey, tell me everything you know about X. So.
Why does the anesthesiologist have so much control over the drugs we carry on the ambulance?
Why does who?
Why does the anesthesiologist have so much control over the stuff we carry on the ambulance?
So that's a great question. And I'll tell you my take on that. So I've been working in the emergency department since the early '89. There was a time in the ED in Cincinnati where we couldn't carry propofol. We couldn't have propofol in the emergency room because that was an anesthesia drug, and they were the only ones allowed to give it. So that lasted until we started calling them in every time we needed to intubate somebody. You have to call the on-call guy, and he would have to come in, go to his little magical Pyxis to get the propofol out, and then carry it to the emergency room and intubate patients. After he had to get up in his jammies about the 4th or 5th time in a week, then they started letting go of that. And I think that has then transferred over to EMS, where they kind of decide what medicines you should be carrying. There was a time when I first started at CRH that anesthesia had a heart attack. They found out in 1 year, I think I had done like 165 RSIs in the ICU. And anesthesia somehow found out that a non-physician was given paralytics and intubating people, and they were like, what? Who has authorized this? And they're like, the whole world does it. And they made like a big thing. And finally, it went to the medical executive committee, and they said, unless you want to station one of your little guys in the funny hats and the shoe covers in the ICU 24 hours a day, 7 days a week, stop worrying about what they're doing down there and worry about what you're doing. And then they finally did that. So maybe so my point is maybe that day will come at some point for EMS. The problem is we don't have very good data that says that paramedics are doing such a great job with RSI. And I'm guessing you're talking about RSI, right?
I mean, just like lactated ringers. I mean, anything that's got to go through anesthesia, the rumor mill for us, me, has to go through anesthesiology. If anesthesiologist says no, then we don't get it.
So every med outside of RSI goes through our medical director. However, those drugs for RSI are owned entirely by them.
They're controlled by the anesthesiologist.
Allegedly, there's a protocol or a policy that says only physicians and anesthesiologists can give any sort of paralytic for Columbus Regional Hospital.
My
So they're working allegedly on changing that protocol. I can't find it anywhere on the entire K drive, but apparently it exists.
So my suspicion is that, that's definitely not true because my partner and I give paralytics all the time in the ICU.
And I can't find it anywhere.
So I'll give you a historical perspective because I've been involved with this a lot in different places. So I flew on the helicopter in Cincinnati for 15 years. I can tell you that generally speaking, without the right kind of training, RSI is done very poorly in emergency departments, in intensive care units, and pre-hospitally, all over the U.S. Most of the focus is on putting the tube in the hole. You can teach a 5-year-old to intubate with a glide scope at this point, really, for the most part. Now, there are some airways that are more difficult than others, but largely getting a view and putting the tube through the cords is not the difficult part. The difficult part is doing it safely without causing hypoxia, without causing hypotension, without killing people with the drugs. That's where it always goes wrong. So unless there's a strong focus on that piece, it is really dangerous. The second problem is, if you look at how often we're intubating people, people aren't getting enough swings at that procedure. I mean, the busiest, most active paramedic at CRH, how many intubations did they do in 2025?
Medic 10, probably, I would say, those that did run, a 10, maybe.
I'd say Chris had more than that.
I had 6 last year. I have 0 this year. I
Right.
haven't seen the patients.
So the same thing. It's not just ground EMS in the air. I mean, I was talking to Justin Spear. He's done 3 this year. So you just don't get the swings at it. And it's a very complicated procedure. And if you don't get the opportunity to do it often enough, it is fraught with complications, right? So I think it's multifactorial is my point, that I think anesthesia doesn't understand what goes on out here. And there are times when if you don't have the ability to paralyze people, you're going to transport a dead person to the hospital. And that's just the reality of it. You know, if you got somebody that whacks their head on a tree and they're puking through clenched teeth, either going to cut a hole in their neck or you're going to transport a dead head to the hospital. The problem is that if that's the only airway you've done in 2026, now you're doing it under the worst circumstances with the least amount of help and the worst lighting. It just makes it a complicated process. So I don't claim to have an answer to that. I think it's very difficult. As far as all the other stuff, like I don't know why anesthesia should have a dog in the fight with respect to what kind of IV fluid you carry. That should be a Chris Schneider thing, and whatever he says is what it is.
So I know when Dr. Guffey was our medical director, he's like, oh, you guys don't carry that? And he was clueless on what we did and what we didn't have. Because it's like the simple things, he's going, you don't have that?
First part is having an engaged medical director, though. I mean, I think Chris is way more engaged than what you had before. He's certainly a good guy. What do you guys do when you call medical control? Like my guys at Let's call me. They have my cell phone, and they don't call the hospital they're going to. They call me. Do you guys? You call the hospital and just get whoever picks up the phone.
Whether they know our protocols is entirely different question, but
More than likely they don't.
Yeah, I would say that's fair. Because I've taken some, when I used to work in the ER, when I would take medical control calls for you guys, like I didn't know what your protocol was. I'd just ask, do you guys have this or do you have that or whatever. Yeah, there should be some degree of familiarity, so they know what's on the table.
Boils down to calling them more too whenever we, like I said, and not like we need to call them all the time, but there are some people that feel like they shouldn't call on certain things and they make their own judgment call just because they don't want to bother them or don't want to feel like they don't know what's going on. And sometimes you can call them just to bounce an idea. So I've done
But if they don't know what you do, it makes their...
But the more that you do it, the more that you do communicate
Yeah.
with them, the more they're going to learn.
Right, sure, yeah. That's, I would say the majority of the calls that I get are just discussion things. Guys are like, hey, I got this kind of weird thing. What do you think about this? I get a lot of calls from, we do really complicated critical care transfers, and they'll call about, labs or blood gases or something weird like that, or vent settings. But for the most part, it's just more of a discussion. So, all right, so what about clinical stuff?
You got anything?
sorry, I got too much audio.
What about DKA? Tell me everything you know about DKA.
You just got a heavy DKA lesson from Justin Spear the last time that we were last Wednesday.
Well, that's perfect. So you guys will have the answers to these questions.
So that was also like the first taste of like hydrogen plus bicarb equals carbonic acid equals CO2 and H2O. I was sitting here, I was talking to whoever's next one, I've never even fucking heard that before in regards to diabetes. Like we've never gone that deep. Sugar's high, give them fluid, go to the hospital.
So explain to me why people in DKA are so dehydrated.
It is a great question.
Does it do with their compensatory respirations? Does that have anything to do with that?
Also, they're also getting rid of them through their urine too.
Well, and also respiratory.
Well, I said and respiratory, yes, but they're also doing that with the urine too.
Okay.
So hydrogen ions are high. Bicarb is being dumped. We're getting a massive inflow of carbonic acid, right? I'm in the right process.
I would say you're in your car and you're headed northbound on the interstate.
Okay.
So
Okay.
so
The
which is better than south,
Carbonic acid
so.
is going to be water and CO2. They're going to compensate by that by breathing off the CO2.
What's that have to do with their
I don't know what
volume
they're gonna do
status?
with the water, though. That's my point. That's
Right.
where the car just hit a tree.
I'm assuming
Yes.
that the sugar is
You
somehow.
got the Taylorsville Taffy, you're almost home.
Yeah, car hit a tree. I don't know. Where does
Yes,
water-
sir.
Is it because there's so much sugar in their blood, it's trying to draw water from the cells to create that
Kidneys?
balance?
Keep going with that. Keep going with that.
Jonathan, you need to go sit in the truck. and make an
You got off at the right exit and you turned the right way off the ramp, and now you're like coasting down this road. You just got to pick a side street.
Metabolic acidosis.
So their blood sugar goes up, right? When their blood sugar goes up, once their blood sugar gets over 250, it starts spilling into their urine, right? That's why you have so much glucose in the urine in diabetes.
Are they even producing urine, though?
Huh?
Are they even producing urine, though?
Well, initially they are, yeah. So their blood glucose spills over into their urine, and now there's more glucose in the urine than there normally is, all right? And they become hyperosmolar. So think about hyperosmolar means that imagine if you have a beaker full of water and you put a couple drops of food coloring in it. The beaker of water is going to be a very, very light blue because that's the food coloring you put in. As you spill more glucose into there, you keep putting more drops of food coloring, that water becomes darker and darker blue. There are more molecules of sugar in that water than there were before you started. Pretty soon that beaker becomes bright fluorescent blue. They are very hyperosmolar. They develop this osmotic diuresis, and the glucose starts going out and the water follows it. And it's just this train of glucose and water spilling out in the urine. And now they continue becoming more and more hyperosmolar because they're losing all that glucose, losing all that water. And it becomes more and more concentrated, and they develop an osmotic diuresis, and they just keep diuresing, and then they're just dry as hell. So you were exactly right. It's because of the glucose. And then they have some insensible fluid loss because they're breathing fast, and they're losing some fluid there as well.
Is there any sort of like increased vascular permeability with that as well?
Initially there is, but after a while then it goes the other way. It just clamps down.
Okay.
So that's why they diurese. And when they're spilling, and what happens is the hydrogen ions, they have the keto acids, ketones are built up. The keto acids go into the cell and push the hydrogen ions out. The hydrogen ions get out of the cell, the potassium gets out of the cell. Potassium then spills over into that fluid, and it spills out, and the potassium gets excreted as well. So normally, most of the potassium in your body lives where? In the cell, right? But when the hydrogen ions go into the cell, it pushes the potassium out. So now the potassium is in the extracellular space. Well, when we draw blood, we're surveying the extracellular space. So normally there's very little potassium in the extracellular space. So what happens is now there's way more potassium in the extracellular space. So you draw the blood and the potassium looks really high. The potassium would be 6 or 7. It's not high, it's just translocated into a place where it doesn't normally live. So once it gets out in that extracellular space, what happens to it? It goes with the sugar and gets spilled into the urine, and then the kidneys just ditch it. So you think the potassium's high, but in fact it's low, right? So these people become profoundly hypokalemic because they're spilling out that potassium. So when you think they're hyperkalemic, they're actually hypokalemic. So what we tell people, what the guidelines say is, once the potassium gets to 4.5, you're going to start giving it back. Because if you don't, what's going to happen is you're going to be pounding them with fluid that doesn't have enough potassium, and now you're going to further dilute their potassium, and now they're going to be dangerously hypokalemic, when in fact you think they're hyperkalemic.
And God help them if they're also on Lasix then.
Yeah, right. That's right. That's right. So it's a terrible set of circumstances. So the hallmarks of diabetes care is there's no need for an insulin bolus. You just put them on a drip. That helps close the gap. You give them tons of fluid to rehydrate them, and slowly their blood sugar will start to come down. When their blood sugar gets to 250, you switch them over to D5.5 so that you can keep the insulin drip on to close their gap to relocate the hydrogen without making them hypoglycemic, and then you just keep giving them fluid. So what I do when I treat these people, somebody comes in and they're sick as shit from DK, I'll give 2 liters of LR up front. If they're young and they have a good ejection fraction, I'll give them a third after those 2 liters go in. And I put them on LR 200 an hour and just keep that running constantly. And then put them on an insulin drip and then just leave them alone. If they'll drink fluids and they promise not to throw up, they can drink fluids. There's no magic to IV fluids. Oral intake is just as good as IV. I'll replete their potassium. I'd like to give it to them orally if I can, because you can give way more potassium orally than you can IV. You can give, I think, 10 milliequivalents an hour IV. I can give you 60 an hour orally. So you can make up ground quickly with oral potassium. And then I just keep giving them fluid, keep giving them fluid, keep giving them fluid. When their blood sugar comes down to 250, I'll check their gap again. If their gap's closed, then I'll give them Lantus, because that's long acting. In an hour, I turn off their insulin drip, and transition them over to sliding scale, and it's fine, and keep their potassium up. So, but the key thing, pre-hospitally especially, lots of fluid, lots of fluid. Young people, if you can give them a liter and a half before you get them to hospital, you're just ahead of the game. So here's the other question. Somebody's hyperkalemic. What's that? What do you know about giving them lactated ringers? Because lactated ringers has potassium in it.
So it's not gonna increase the hyperkalemia. It can kind of balance out their potassium. Is that correct? It doesn't. What is the way Justin explained it? Because I was watching that YouTube video.
That's a great question.
He was talking about how LR doesn't add to, doesn't take away. It's like kind of neutral.
Sure.
What do you guys got?
All right.
Where's my fire whacker guy? What do you got on that? He's the biochemist. What do you got on that?
I missed that class, but it sounds like from what he said, if it's isotonic, then it'll stay in the vascular space and not go into the cells.
Right.
I don't know, that's my best guess.
Anybody got anything else?
No idea.
I'd agree.
I agree. All right. Here's the simple answer. People who are not very clever think that if somebody's hyperkalemic, LR has somewhere around 4 to 5 milliequivalents per liter of potassium in it. So what people used to think is that if your potassium's high, 6, and you give them IV fluid with potassium in it, that it is additive and it would add on to the potassium that's already in the serum, and now it would be 6.3 or 6.4. It would continue to add up. What we know is it's a gradient. So if your potassium is 6 and the LR in the IV fluid is 4.5, what will actually happen is it will bring your serum potassium down, because the potassium in the IV fluid is 4.5, your serum potassium is 6. So because of osmosis and diffusion, it'll actually bring the potassium in your serum down if you gave enough of it, because it's actually a lower concentration and will lower the serum concentration. So 1 liter of LR is not going to measurably lower your serum potassium in your body because it's not enough. But the principle is that it creates a gradient and would actually theoretically lower it, not cumulatively make it higher. Does that make sense? Yep. All right. So that's an important concept. So we see that sometimes, like you go to the little hospitals and somebody is hyperkalemic and they're hypotensive, and you give them, an LR bolus, and some of the ER physicians that, aren't emergency medicine trained will get excited about it. You can't give them LR because it's got potassium in it. Go do a rectal exam or something. It'll be fine, It doesn't work like that, right? Just doesn't work like that. All right.
I got a question. Speaking of potassium, can we go over like the differences between hyperacute T waves and peak T waves?
So let's talk about that. So we used to think that there's this really cool chart that talks about what potassium does to the P wave, the PR interval, and then the T wave, and how you could track what the potassium is based on these EKG changes. What we know now is that's probably not true. Has everybody heard of, in hypothermia, what's the EKG manifestation of hyperthermia? I'm sorry, hypothermia. The Osborne wave, right. So seen frequently on the boards, never on the wards, right? So if you pick up somebody that you think's hypothermic, if you're looking for the Osborne wave to tell you they're hypothermic, the ship has left the harbor and you are not on it. All right? So what I will say to you is this. If you have somebody that's hypothermic and you're like, holy shit, that guy's got a core temp of 32. And then you look at the EKG and you're like, I wonder if that's one of those Osborne waves. That's the value of the Osborne wave, not the other way around, right? EKG changes, T wave changes in hyperkalemia are the same. You can have someone who is profoundly hyperkalemic who does not have EKG changes. You can also have someone who is profoundly hyperkalemic who has crazy giant T waves. So I wouldn't use that as my marker. What I would say to you is this: anyone who has unexplained bradycardia is hyperkalemic until you know they're not. So if you have somebody, you get there and their heart rate's like 30s, 40s, and you're like, why the fuck? He's hyperkalemic until you know he's not. Now, if he's having an inferior wall MI, then that's a pretty good explanation for somebody to be to be bradycardic. If they have sick sinus syndrome or something else, then that's a good explanation. But anytime I pick somebody up who is profoundly or significantly bradycardic and there's no explanation, they get calcium. Or has some kind of wide, crazy looking bradycardic QRS, give them calcium. And that will be your instant answer. If you give them calcium and you see their QRS narrow and their heart rate come up, there's your answer. You have to give that calcium every 20 to 30 minutes though. If you're in a long transport, you might have to repeat it because they burn through that calcium pretty quickly.
So how does calcium narrow the complex?
So calcium just stabilizes. So what we think is that calcium stabilizes the membrane. There has been some evidence lately that says that where they really studied it and they're like, I don't know if it really does that or not. It probably is just one of those things that we know that it improves the cardiovascular side effects of hyperkalemia, but it may not be for the reason we thought it did. So there has been some evidence recently that says that whole stabilizes the cardiac membrane, that might be horseshit. But I don't think we know for sure. But we still know that it works. It just may be one of those things where we don't really know exactly why.
That was one of the things they taught us in school, and they told us we wanted to make a QRS complex a little bit more narrow to get sodium bicarb, so that's also a lot of...
So if they are a tricyclic antidepressant overdose and they have a wide QRS, you just keep pushing bicarb until their QRS narrows. But that's because tricyclic antidepressants work on the slow calcium channels.
Okay.
And sodium channels.
All right. So
I want to shift gears again.
Yeah.
So we were talking about this with Justin the other day. Are we not going to be giving bicarb to crush injuries anymore? We were talking about this. We said, so crush patients, they've been crushed for an hour, give an amp of bicarb before you lift whatever's crushing them off of them to prevent the heart from going into an arrhythmia and keep it getting narrow, right? Says we're going away from that.
it takes that
Now
hour.
why? What's up with that?
So I don't think we really know. I think that, so there are a lot of things that we do. There are some things we do because we have evidence that supports it. For instance, everybody was taught that you give nitro to people having chest pain because it dilates the coronary arteries and it improves morbidity and mortality. We know that's probably horseshit, that it does not impact morbidity and mortality at all. But everybody is given nitro to somebody having an MI that's pressure then goes to 40. They get pale and sweaty and look like they're going to die because they overreacted to the nitro. So there's not really great evidence for that. We know that it does not have a mortality benefit. Aspirin, we know beyond a shadow of a doubt that it improves mortality in acute coronary syndrome. Aspirin works. There's tons of good evidence to support that. So there aren't a lot of things that we have really good evidence that says that we know that it works. And in the absence of that evidence, just like I talked about jumping off the helipad, there's no evidence there's been no studies done that say if you jump off the 10th floor helipad that you have a greater mortality than if you jump off the 15th floor. There's no study that's been done, but intuitively we're like, looks like a duck, walks like a duck. I don't have to see duck shit on the floor. No, there's a duck out there. So in the absence of that evidence, we have to go based on physiology. And the physiology is that in crush injuries, that bicarbonate should help to alkalinize the urine and should improve mortality. The downside is almost nil, and the theoretical upside is present, so we do it. Given calcium when we give blood. We know that the preservative in blood is citrate, and citrate degrades calcium. So when we give more than a couple units of blood, we give calcium to prevent the degradation of the calcium by the citrate. There's no randomized controlled trial that proves that that impacts mortality, but physiologically it makes sense, so we do it. Almost all medicine with kids, it's very difficult to get kids in randomized controlled trials because nobody wants you experimenting on their children. So there isn't a lot of great evidence surround pediatric medicine. We just do things based on what physiology dictates. So that's one of those things. Does that make sense? That answer your question?
Yeah. So we're still gonna do it.
Yeah, right. So I think I'm still doing it. I think it's sound practice to do it. Let's talk about the Parkland formula.
There's a nurse at Eskenazi that loves doing the Parkland formula, and I can't wait to send my patient to her.
So the Parkland formula is a bunch of horseshit, right? It's another great test question, but we know that I have one of the guys that I teach with at Heavy Lies the Helmet is the director of the burn unit at VCU. VCU was the first civilian burn unit in the United States. It's over 100 years old. They're on the cutting edge. They're growing skin down there in labs and putting it on people and all kinds of crazy burn stuff. They've done lots of research that looks at people that we use the Parkland formula on, all arrived to the hospital over resuscitated, over volume resuscitated. And now they get intubated and placed on mechanical ventilation because we gave them too damn much fluid. And they're cold because we're giving them cold IV fluid on top of it. So in summary, what they recommend is adults with critical burns get 500 cc's an hour. Children with critical burns get 250 cc's an hour. Infants get 125 cc's an hour. That's it. Nobody can do the damn Parkland formula anyway. Like, who knows? First of all, you're always going to be wrong when you guess what their BSA is, right? I mean, no matter what it is. You're like trying to do this hand thing and the 9/18. Who knows what any of that horse shit is? So it just, if they're burned, an adult, 500 cc's an hour. So if you're 20 minutes out from the hospital, I give them a couple hundred cc's and be done with it. Unless they are a trauma patient, you know, it's an explosion or something, and then they need blood resuscitation, different animal, they have concurrent trauma. But if it's just burns, isolated burns, can't figure it out. Who said that? Patton, that's right. General Patton said that. Never come up with a plan so ingenious the troops can't figure it out. So there's a little something extra. There's a little nugget from me to you. All right, what else are we going to talk about?
RSI. This is one of the things that's becoming new to us probably this year in August. Foreign concept, it's kind of almost been worked up to be terrifying, but it's really not that big a deal. If you do it correctly, if you follow an algorithm, the formula, super simple. I am concerned. Innovation first pass success rate is critical, I think, for RSI. I'd like to see our numbers higher. However, we're going to send it no matter what. So, huge indications for RSI. Obviously, respiratory failure, respiratory arrest, right?
So let's talk about that.
Yeah.
That is a huge, that's a crusade of mine. So a whole bunch of pearls on RSI. Number one, when you are intubating multi-trauma patients, the first question you have to ask yourself is this patient dying an airway death?
The majority of the time, the answer is no. Leave them the fuck alone.
Thank you.
We are assassinating people with RSI that don't need it. The hemodynamic consequences of RSI are enormous, enormous. I cannot tell you how many people I have seen exterminated by EMS crews, by emergency department staff, by flight crews, by doing RSI in people that didn't need it. Most of them do not. People who are bleeding to death need blood, and they need hot lights and cold steel. That's what will save their life. All of the other stuff will hasten their mortality. We do RSI often for the same reason the dog licks his own balls. Because we can, not because they need it. It is very dangerous. Let me tell you a story. A year before I stopped flying, we flew out near Kings Island for a girl who was her and her husband were competition bike riders. You know, they wore the little silk drawers with the padded butts and the funny hats and the crazy shirts, you know, all that ridiculous attire. And they rode like 150 miles a weekend or something, riding all over the place. Fantastic shape. A hillbilly on the north side of Kings Island wasn't paying attention and macked her with his minivan and essentially drove over the top of her. When we got there, she's already in the ambulance, and as we got in, I stepped up in the ambulance and looked at the monitor. Her heart rate's 160, her blood pressure's 70, and she's completely unconscious. White as a ghost, looks like 30 pounds of beat up dog shit. I took one look at her and thought, holy fuck, she's dying right here in this ambulance. Stuck my head out the door of the ambulance and went like this to the pilot, means stay running. And I drilled her in the shoulder, which is where we should drill everybody, not in the legs. Stop drilling the legs. If you are afraid to drill the shoulder, see me before we leave and I'll show you how to find the spot in the shoulder. Stop drilling the legs. I tell all of our people at Let's, you get one free one and now you can't do IOs anymore. Shoulder, the end. Okay, all right. Doing my therapeutic, but doing my own rescue breathing. All right, so I drilled her shoulder and hung blood to the helicopter. She has a GCS of about 5. She is not dying in airway death. She is dying a hemorrhagic shock death. We flew to the U, landed, went to the ER, and I called and said, I think we should go direct to the OR. She's dying. They're like, we're just going to take a quick look at her and then we'll go to the OR. I've seen what that quick looks like, you know. So go to the OR. I'm cleaning up my cot. I walk out to get the handy wipes to clean off the EKG leads. I come back in and they're pushing the ketamine to intubate her to take her to the OR. Within 4 minutes, they were opening her chest and they left her dead carcass in the shrew at UC. They killed her by managing her airway. That is a common problem in trauma. We are taking people who are not dying in airway death and we induce an airway death on them. So that's my first pearl of RSI is ask yourself, do they really need their airway managed? And if this goes south and I can't manage their airway and we're doing compressions in the next 5 minutes, can I justify why I did this? And in some cases, the answer is yes, and you have to do it. You know, you have somebody who's puking through clenched teeth and now their heart rate's 50 and they're dying right in front of you. They need RSI. There are people that need RSI, right? But the 70-year-old guy in septic shock with a blood pressure of 80 who's minimally responsive doesn't need RSI. He needs a blood pressure. He needs to be resuscitated, and then he'll probably wake up because he's perfusing his brain again. But if you RSI him with a blood pressure of 80, you're going to exterminate him. I don't ever initiate an RSI unless your systolic blood pressure is 140, ever. And I'll just keep giving you push dose epi until your blood pressure is 140. Because think about how many times in your careers you've been in the ER, you've been in the field, you see somebody get RSI'd tube goes in, everything's good, next blood pressure is 60. It happens all the time because there are hemodynamic consequences to positive pressure ventilation and the pharmacology. So you have to restore, you have to make sure their oxygenation is intact and their hemodynamics are intact. We can gain a lot of ground with non-invasive ventilation. RSI can be pretty squirrely pre-hospitally. I mean, sometimes we're shorthanded, sometimes we're in less than ideal circumstances. You just have to make sure that it's the right thing for that patient, not just, you know, the dog licking himself, right? So that's number one. Make sure they're adequately oxygenated. Pre-oxygenate everybody. Everybody gets a 15-liter nasal cannula. Everybody gets a non-rebreather over the top. Or they get a 15-liter nasal cannula and CPAP over the top. Don't hesitate to use non-invasive ventilation. And then it doesn't matter, and that's the other thing. You don't need a gag reflex for non-invasive ventilation. You are their gag reflex. You're sitting right next to them. Don't use their absence of a gag reflex as a reason not to provide them the benefits of non-invasive ventilation. You are their gag reflex. It's one-to-one in the back of that ambulance. If you're staring at them and they're on non-invasive ventilation, if they start to throw up, you can take the mask off of them faster than they could pull it off themselves if they were conscious, right? So just assign one person. I want you to do nothing but be his human gag reflex. And if you put them on non-invasive and a 15-liter cannula, now they start to wake up and their SATs are 98%. Do they really need RSI at that point? Just be judicious with it is my whole point. I'm not trying to talk people out of it. There are times when it just needs to happen. And in those cases, then we need to do it. But just make sure that risk versus reward, right? You pull up on a car wreck, you got somebody trapped in a car, and you're worried about a spinal cord injury. So yeah, we take the roof off, we cut all the doors off, we pull the seats out, we do all the things. We take 30 minutes to take him out of the car. There's times when that's the right choice. There's other times when you walk up, you take one look at the guy and you're like, holy shit, he's dying in that car. You grab him by the head of the hair and the seat of the pants and you drag him out the window. There's times when that's the right choice. Just make sure that you're making the right choice for that patient and that you can defend it. And if you have to walk out to the waiting room and say, hey, I just killed your dad by giving him drugs and trying to intubate him, that you can say because I had absolutely no choice. Just make sure that it's the right thing to do.
That kind of sounds like when I did my medical rotation at the OR, or an anesthesiologist up there that would need to stand there and bag the patient before you intubate. And he preached that you can adequately ventilate somebody without intubating, but you get to stand there a couple of minutes and bag the patient and, watch the pulse on it. And he's always said, if you don't get somebody intubated, but you just bag bound them nice and neat. Don't take no crap from the doctor in the yard. Don't let him belittle you because you can adequately ventilate somebody without having to shoot.
Absolutely, absolutely.
But it almost, I know it's kind of hard up, of course. We were doing that RSI situation, but would it almost, because like I said, what actually should be RSI for safe reasons, correct? Would it almost be better to, or it would have been better to work with anesthesiology in their department to show our skill base in their department in a controlled environment, and then showing, when we do actually need it, showing our capabilities on the street when it's only necessary.
That would be phenomenal if we could get our medics in that OR. Do I think that's ever gonna happen?
Even if it's not all of our medics, if we're looking at only doing lieutenants anyway, it'd only be our lieutenants.
So
And they're making sure they're competent.
that's a fair point. I'll tell you, so at Let's, where I'm the medical director, nobody does RSI until they've done 20 airways in the OR. We require anybody that does RSI to go to the OR. Our EMTs go to the OR to put in eye gels. So all of our medics have to get 20 airways a year on live tissue before they can do RSI. So we send them to the OR to do that. I think that's important. So to address your point, we need to talk about bag valve mask ventilation. That is a two-person skill all the time, 2 people. One person puts in the oral airway, seals the mask on the face, the next person squeezes the bag. We squeeze the bag 8 to 10 breaths a minute. It's not catecholamine-induced hyperventilation, where the average rate of ventilation is 40 to 60 breaths a minute. Look at the next time, watch the next time you see somebody getting bagged. Look what the rate is. How in the world does everyone not puke like a maniac when we bag people at 40 breaths a minute without an oral airway in? I mean, there's no way your glottis can take that much air. The average tidal volume of a bag valve mask is somewhere between 12 and 1600 cc's. The average tidal volume for a human is between 400 and 500. So they need about a third of that BVM. And when we breathe, we're breathing at 400 to 500 cc's a minute, about 8 to 10 times a minute. Now we're giving somebody 1,000 cc breaths 40 times a minute, because whoever's squeezing the bag is all jacked up, right? So we got to slow down the rate. We've got to position the head, put in an oral airway, one hand on one person doing the mask, next person squeezing the bag, over 3 seconds. That will profoundly improve the oxygenation. Other thing you have to really consider is on these 100-year-old people that we're bagging, is the right move to take their teeth out. So when you take their teeth out, what happens to their face? Their whole face collapses. Now you're trying to seal a mask on a face that's not there anymore. They have the maxilla and the mandible and everything else is gone. And you're like trying to, so you get the mask on there, you bring their face up to the mask, you have a good thumbs down, and you have one person squeezing the bag. That makes all the difference in the world. You will be able to ventilate almost anyone if you always use an oral airway. And the way to remember that is you use it every freaking time. Every time you use a BVM, you use an oral airway. Every single time, without fail. And if they're fat, which is my size or bigger, they get nasal airways too. And then you put the nasal cannula through the nasal airways and the BVM at 20 liters a minute, your oxygenation just skyrocketed, right? So those things. Push dose, do you guys use push dose epi?
Yes.
All right, so push dose epi is the greatest thing ever, because no, everybody's just making excuses why they can't start the drip anyway. Just use the push dose epi, right? I'd use push dose epi probably every day at work. Generally speaking, for every cc of push dose epi you give, you're going to get about 10 millimeters of blood pressure support. So use that as a guide. Ketamine, half dose ketamine for people in shock. Ketamine will, I don't care what they tell you about it's blood pressure stable, it doesn't lower your blood pressure, that's complete horseshit. Ketamine will tank your blood pressure in a second, especially if they're catecholamine driven. You get somebody just got macked by a truck, their heart rate's 140, and they're laying in the middle of the road fighting for their life. Anything you give them is going to have hemodynamic consequences. Anything is going to have hemodynamic consequences. So just be aware of that. Ask yourself, are they dying an airway death? That's the first question you have to ask. Because if they're not, don't induce an airway death on them.
I think we've already put a guardrail in for that ketamine as well. We went from 1 to 1 to 0.1 mg per kg. So I mean, for pain. So for that guy, he says 100 kilograms, he gets 10 milligrams of ketamine. That's it.
Yeah, ketamine for pain, because the research says that the closer you get to 0.3 or 0.4 of ketamine for pain, closer they are to the K-hole, and then they have freaking out, and now you're fighting them, and they're seeing purple, elephants and all kinds of crazy stuff. So the lower dose is just as effective.
So this is something that's not touched on often. Ketamine is just dissociative, correct? So
It's at 1 mg per kg or above.
Music with that a lot of times too. So should we be giving prescribed it and some fentanyl to go with that.
Nope, ketamine's one-stop shopping.
One-stop shop.
Yeah. So we see that all the time at Let's. We pick up people from these little hospitals and we're transferring them, to Indy or Cincinnati or whatever. And the ER just starts them on propofol. Propofol has no analgesic properties. So you go and pick these people up and their heart rate's 104. I got one last night, and I won't say where they came from, but the guy comes in. He is diaphoretic, like you just sprayed him down with a garden hose. His blood pressure is 150 over 100. He's got tears welling up in his eyes. His heart rate's 120, and he is fighting for his life because they ran out of fentanyl on the way from where they were going to the ICU. We just ran out of fentanyl. And the doctor didn't give us an order for more fentanyl. One dose of ketamine, I gave him, as soon as he rolled in, I looked at him like, holy shit, what's the propofol at? 25 mics. He's got no analgesia, he's got propofol at 25 mics. It's like peeing your pants in the dark. So give him 150 of ketamine. Push 150 of ketamine, 3 minutes later, recycle the blood pressure, 120 over 86. He was screaming in his head.
That's gotta be the worst.
Oh my God, it's just so terrible. So ketamine is sedation and analgesia. But you got to do 1 to 1.5 per kilo. But it's going to have hemodynamic consequences, not as much as propofol. Propofol's semen of the devil. But ketamine is much, much more hemodynamically stable than propofol. But I mean, in people, that's why anesthesia loves propofol, because they're putting to sleep healthy people largely, right? Propofol is a great drug for healthy people. Propofol is a terrible drug for people with cardiogenic shock that are hemodynamically unstable or people that are bleeding to death. It's a terrible drug. That's why we would call people that give propofol to them, we call them the propofol assassins, because it's blood pressure of 50 for everybody. And old people with a blood pressure of 50 are now not perfusing their coronary arteries, and you're inducing a non-STEMI by giving them propofol and dropping their blood pressure. So that's the long and the short of it on RSI, as far as I'm concerned. I think it's an important procedure, but you got to respect it, and you've got to ask yourself, are they dying an airway death? And you guys have video laryngoscopes, right? Yeah, so.
ProView, something like that.
Yeah.
Great value.
I hear that's what we're getting in the ICU now. We always had GlideScope, but I guess ProView's cheaper.
They're really not bad.
So there's a reason why GlideScope has the market share, You could take wedding pictures with those damn things. That's what we use at Let's. I have a GlideScope in my car. That's because I have all the equipment in my staff vehicle. So I may just take my own GlideScope to the ICU with me. So, but having some video laryngoscope is the key. The UE scope, that thing is a hunk of garbage that should be made by Fisher-Price, but I think the other ones are, I think a lot of people are using, in Cincinnati area, everybody uses the McGrath. Is the McGrath popular around here?
Yeah, I know Jennings has McGraths, which really isn't saying a whole lot, but I like McGraths.
Well, it actually is saying a whole lot.
Yeah.
Jennings, yeah.
Jennings has McGraths too. Whenever I've intubated there, they've had them. But I like you can video record your intubation with McGrath.
Yeah, the GlideScope is video records too.
That's kind of nice. I think that'd be good for like QA, QI purposes.
We just attach it to our chart. So and we have the bronchoscope as GlideScope also, so they're interchangeable. So, all right, what else?
On that, the whole video scope thing, what don't you think, I know there's several paramedics that's never even seen real live vocal cords through their own eyes.
Like direct?
Shouldn't we be teaching how to use them manual over playing a video game? Right?
So, spoken like an old guy, right? As an old guy, like I feel you, right? I'm with you. So I have always thought that we should teach people direct, and then we should, morph to the video. I taught for a bunch of years in the difficult airway course, which is a nationwide, international course for in-hospital and pre-hospital providers. There's a pre-hospital course and an in-hospital course. And I espoused that. And the anesthesiologist who developed that course is a guy named Ron Walls. And he challenged me on that. He said, you know, the evidence says that first pass success profoundly higher with video laryngoscopy, right? Like 80+% compared to like 60%. He said, if somebody came to you in the waiting room, he asked me, he said, do you have kids? I said, yeah. He said, if somebody came to you in the waiting room and was consenting you for a procedure on your child, and he said, we have a couple options for how we're going to do this procedure. One involves a device that has been designed within the past 15 years that has a 30% higher success rate. Or we have another alternative that is 80 years old and has a 30% lower success rate. Which would you prefer we use on your child? And I'm like, all right, I guess I get the point. So what we always talk about is, well, what if the video laryngoscope fails? You know, and you don't know how to do DL, then you're at some disadvantage. The evidence says that the video laryngoscope is very unlikely. What if the defibrillator fails? What's our backup for that? You know, you can only have so many redundant systems. If the first pass success rate is higher, we should just go with the modern technology. I am kind of like you. I think people should learn how to use DL first and then go to VL. There are some of the blades that are not hyperangulated that you can use, you know, DL. I think, I don't know. I think we probably should get with the times. It pains me to say that because it pains me to say that. Are you guys, does yours have the hyperangulated blades as well as standard geometry?
No, ours are just hyperangulated.
So, you know, the challenge with hyperangulated blades is you can't really use the bougie with it, right?
We
But
got the stiff,
The rigid stylets.
right, right. Which is still not one-stop shopping, right? I think it's important. I think we should have both because there are some people that you need to use the bougie with just based on anatomical considerations. Somebody has subglottic stenosis or whatever. But I don't think it's often we train people enough that the technique is different for VL, right? Like with the hyperangulated blade, like how you get the view is different. Like with direct laryngoscopy or standard geometry, you're actually using it like you would the old-fashioned laryngoscope. You know, you either put it in the vallecula or you're actually lifting the epiglottis. But with VL, you actually want to be further north and not actually be trying to displace the epiglottis. We're trying to maximize the view, and then the stylet will deliver the tube to where you want it to go. If you are ever intubating with the hyperangulated blade and you notice the tube keeps going south, it means you're too deep. You got to come back, and then the view won't be as good, but the tube will go right where you want it to go. So that's, I mean, it's kind of hard to describe without doing it, but just things to keep in mind, right?
We've also looked at, like I said, we did, what do we call it, where we innovate with the decanter.
The salad.
Yeah, salad, yeah.
Yeah, I think that's, you know, they get really fancy with that.
But I'm saying, like, that way, if you're having one of those that's difficult, that you would normally use a bougie on, you can still use that method and still be able to, because I have used those on some difficult.
Yeah, the decanto, the salad technique is certainly helpful. I mean, I feel like we've been doing that for 25 years. We just didn't call it that. We just crammed the yonker down their throat and let it suck away while we're trying to get a view. But yeah, I think that's it's just a larger bore. I mean, Jim Ducanto is a great guy. He actually taught in that difficult airway class. He's a very interesting character who could now buy his own island, you know, somewhere. But he's came up with a very simple, you know, I mean, for anybody that's been a paramedic for a long time, you always thought, why the hell is the hole on the end of the yonker so damn small? And he was like, maybe we'll just change the angle a little bit and put a bigger hole in there. And now he's printing money in his basement, you know. I mean, it's genius, really. I mean, it's super effective.
Have you
And
seen the Walls Manual of Emergency Airway in, but still worth the buy.
Yeah, yeah. That's Ron Walls, the guy that I was talking about. That, yeah, he's the one that did that class. So, well, yeah, good luck on that. I think the key to success with the whole RSI thing is to train everybody up so you guys are doing it exactly the same way. You know, that you have an airway checklist, you go through that checklist, and everybody does it the same way, you know, and gives push dose at the same threshold, and hyperoxygenates, pre-oxygenate, all of those things. And then uses the same drugs. I taught in a place over in Ripley County. I was teaching them how to do RSI. They carried rock, sucks, and vecuronium, all three paralytics. Like, what? Why are we making this so complicated? Like, one paralytic and one or two induction agents. I think there's a place for etomidate. And etomidate, the other thing is etomidate, do you guys carry etomidate now?
Unfortunately, yeah.
So that's a one-time thing, right? There's another place that's given etomidate, multiple doses of etomidate, using it for post-intubation sedation, which is not a thing. Like, it's never been a thing. It's not a thing. Like, I don't know what they're doing, but it's not a thing. So, yeah. So, well, good luck with that. It's a big undertaking, but it's I mean, it's probably a necessary step, especially for services as busy as you guys. That, I mean, you guys see a shitload of sick people. So, all right, what else?
Rock versus sex, polarizing versus non-polarizing.
Oh yeah, there's no choice. It's all rock. Yeah. I took sucks off our vehicles at LEDs. It's just overcomplicating the mousetrap.
Right.
There's no contraindications. There are times when in my practice, I use sucks for bougie changeouts. Like if there's one particular EMS agency that comes in, always puts in 6.0 ET tubes for some reason. So I always have to change those out, and I give them sucks because I don't need them to be paralyzed for 45 minutes just to change out the ET tube. But for RSI, I always use rock. And just guess for dosing, the optimal dose is 1.2 mg per kg. 1.2 is too complicated to calculate, so just use one, just guess them heavy. And just round up. And then you're getting closer to 1.2. Those are optimal intubating conditions for those people. So always put your paralytic in a 10 cc syringe. Always use the anesthetic in a 20 cc syringe. And then you always know what you have. And you just use the same thing every time. And that way, when you have a 10 cc syringe, you know automatically that's the paralytic. And, you know, it's just consistency. The key is consistency, doing it the same way every time. Everybody doing it the same way every time.
How do you feel about pressors and trauma in severe hemorrhagic?
I think it's not a great idea. I think it's not a great idea. Blood.
It feels icky when people suggest it.
Huh?
It just feels gross when people suggest it.
Yeah, I think, I mean, if, you know, the reality of it is here in Columbus, where the closest trauma center is 45 minutes away, it's not like you're 5 minutes from Eskenazi, and if I goose them with a little bit of epi, we're going right to the OR. Here, if they're that unstable and their blood pressure is 20, and they're peri-arrest, you probably should call a tracho, you know, because you're not going to be able to get them to the OR in time, and they need blood. I mean, where are you guys at on blood?
It's a great question. Hopefully beginning of next year, we're close. It's our blood bank, I think, is the issue. Something about the exchange program, they're not willing to do the exchange right now. I don't know. It's above my pay grade.
So that's the problem. It is a very onerous process. We have blood outlets, obviously. It was very painful. We have a $15,000 blood cooler in our chase vehicle that has a 6-day backup battery that it could be essentially in the Mojave Desert, and it would still keep the blood cool, off power for 6 days. It sends text messages out when, you know, the temperature varies by 0.1 Celsius. I mean, it's a very elaborate, expensive thing. In Texas, where the whole blood effort started, they have a very elaborate system. They have a less than 1% waste rate on their blood. So it starts, ground EMS. Ground EMS carries it for so many days, then they transport it to the air medical service, to the helicopter, and then the helicopter carries it for X amount of days. Then they transport it to the trauma center, and then it stays in the ER at the trauma center for so many days, and then it goes to the OR where it gets used. So they just have no waste, essentially. They also are carrying mostly whole blood, which has a much shorter shelf life. So we carry components at Let's because Hawksworth doesn't give whole blood to anybody but UC Air Care. So it's packed cells and plasma. The shelf life is longer, the cost is less, but they won't take it back. And we have, I mean, our cooler is just as fancy as that. We're using the same cooler they are. We have the markers on the units themselves, but they won't take it back. So it gets wasted, which is a very painful thing to do when you think it's such a limited resource. So we need a better system here in the Midwest to prevent the wasting of blood. Are you guys looking at component or whole blood?
Probably more ideal to go with components though.
It certainly is, because the hospital's not using whole blood. We don't give whole blood within the hospital. So I don't, you know what I mean? So it would make more sense. The shelf life's longer, and you're using the same product that the hospital is using. But you know, that's an administrative thing. I mean, the cost, will you guys just put it in the supervisor vehicle?
Yeah, it should be in chase truck.
So like a couple unit, like 2 units?
Yeah, probably 2. I would assume no more than that.
And then what kind of warmer?
Great question. I'm not on that team that does, yeah.
So
how do you feel about, like, New Orleans is doing it, the cold blood?
So that's another one of those things that we have somewhat limited data.
Right.
I can tell you that I don't ever give blood in the ICU that's not warm.
Right.
I give all warm blood because I believe in the military data that looks at the triad of death and trauma. New Orleans, I think to say that we can't afford it, so we don't have warmers. And it looks like there's no mortality benefit to giving it warm anyway. I think that's kind of a backwards way of looking at it. I think it's kind of horseshit. I think that the simplicity of the warming system that we use, I could teach the guy from White Castle to set up our blood in 5 minutes. It literally is that simple. And it's fast. The warmers that we have are better than what we use in the hospital. We use the Q and flow, which is, I think, really the gold standard. It's integrated into the tubing, and so when you hook the tubing up, you literally just pop it down in this little thing. It's on, ready to go. I mean, it's
what Newcastle uses as well.
Yeah.
They came and did an education during, we had a day that was all ultrasound and blood up at medic school. They came and did a little education on their blood transfusions and stuff. It was actually really enlightening.
Yeah, it is life-saving. Everybody thinks that the blood is going to be, you know, you're going to have all these crazy trauma patients. The people that are going to get are the medical patients. You know, I think it was Newcastle looked at theirs. The first 5 times they gave it was postpartum bleeding, which you would think is like, you know, not very common. But the GI bleeds, we get a ton of high-end GI bleeds here in this area in the Midwest. So I think that would be, those are going to be patients that are going to get a lot of it. But it's fantastic. It's fantastic. So I think you guys will use the shit out of it.
Are you guys using ultrasound quite a bit? That's my follow-up question. Right. And are you guys doing ultrasound-guided pericardiocentesis?
Mm-hmm. Yep.
I know.
So yeah, I think everybody thinks that the indication for ultrasound is fast scan. It's not at all. Fast scan is minimal value pre-hospitally, especially here in a place like Columbus, because you're flying them anyway, right? Where ultrasound is going to benefit you guys is undifferentiated hypotension. When you go to somebody's house in the middle of nowhere and their blood pressure is 60 and they're 60, I mean, how do you decide, is it cardiogenic shock? Is it hypovolemic shock? Is it septic shock? You're just pulling it out of your ass. You're just kind of looking at him going, oh, I think he's probably dry. Why do you think that? Well, I don't really know. So we'll give him 250 cc's of fluid and see what happens. But I think we're better than that. You put the ultrasound probe on their heart, you're like, his LV is fine. Give him fluid. Or his LV is terrible. Give him pressors. That's where I think the money's made. Yeah, it just tells you what the etiology of their shock is. And then for pneumothorax identification. So many people, pre-hospitally across the planet, paramedics are just needling everybody. Needle thoracostomy is not a treatment for pneumothorax. It's a treatment for tension pneumothorax. But anybody that doesn't have breath sounds gets a needle stuck in their chest. And that's not without complications too. So you look for a lung slide. Literally, you could teach a 5-year-old to identify lung slide on ultrasound. It's very easy, and it's high yield, and it's fast. So I think that's another huge benefit and then peripheral guided IVs. Right. So we can stop putting those IOs in the leg.
How do you feel about distal femur IO?
I think
still an IO in the leg?
It's still an IO in the leg. It's still a long way from the heart.
Fair.
I can tell you my experience. I've done 2, 3 humeral head IOs in my life. Only because I just put them in their neck, But I'll tell you my story. I had a GI bleed at CRH. The guy was bleeding to death in front of me, like variceal bleed, like it was something out of a horror movie. And we're in the ICU and we're trying to band his varices with endoscopy. And this guy I've already given him like 8 or 9 units of product, and he's bleeding like a stuck Aborigine. And they're GI's in there trying to band him, and it's dark, and they got drapes, and they got that damn bronch tower that's the size of a fire engine, and like you can't get to the guy. And now he's got all these crazy ass drugs going, and like it's just dogs and cats living together. And we just can't, I can't get to him to get more blood in him, and I can't get to the central line, and it's just a disaster. So I'm like, screw it. He's got no veins. He looks terrible. His blood pressure's 50. So I'm like, just give me the eye. I'll just drill his shoulder. And I drilled his shoulder and hooked that blood up. And that blood, we had one nurse that couldn't keep up given the blood. It was going so fast through that IO. Like it was like we were squirting it in a garbage can. It was going through that IO so fast that, I couldn't believe it. And I was, for then, a believer in humeral head IOs. Like, it is unbelievable how fast you can give blood through that damn thing, as opposed to dicking around with that tibial plateau. Yes, sir?
Would you even do that in PEDS patients too, or stick with?
I would say if they're big enough that I feel like I can, find their anatomy, yeah. Yeah, kids are just little adults. That's my thing. If they're not little adults, then what the hell are they, right? Children's Hospital feeds us this line of horse shit that somehow kids are some special creature that we have to do all these crazy things, and it just further mystifies something that we're already freaked out about in the first place, right? They're just little adults. So I think we should just treat them like that, and then it just makes life so much easier for us, Have all these Broslow tapes and all these things we put on them. They're just little people, So, and the children's people always, have their own, frothy diarrhea when they hear you say that, but it's because it demystifies their process. Now, if they're under a year, different animal. Those are neonates, and that's a whole other thing, right? But once, 3, 4, 5, 6, they're just little adults, man. Just, don't be paralyzed with choices, right? It's like when you go to the Cheesecake Factory, and you open that menu up, you're like, hell, I don't know what the hell I want, You go to someplace like E Old Fish House, it's pretty straightforward. You getting a fish sandwich, or you're not getting a fish sandwich, Just makes it much easier. So, I think same for kids. So, other questions? This is Chance?
We'll molest your brain all day if you like.
Well, there's not much in there. We got, 15 minutes? Tammy's the boss.
We've got this till 12:30.
12, geez, 12:30, it's like through lunch.
Yes. You mentioned warm fluids a while ago, and how do you feel about that in the middle of the summertime?
Warm fluids in the middle of summertime? So I think we always have to be mindful of what the temperature of our IV fluids are, right? You know, they're in the ambulance, in the firehouse. I mean, they're probably, what, 70 degrees? So, and if your body temperature is 98, you know, or 100 or whatever, I mean, those are still cold fluids, right? And if you've ever been in the ER, if you remember back to paramedic school, when you're giving people, you know, a couple liters of fluid that's got diarrhea or something, they're always complaining of being cold, right? Because it's cold to them. You know, it's 20 degrees less than their body temperature, sometimes 30. So I think it's something to be mindful of. We use our warmer, we use the shit out of it because the tubing's not that expensive. And I mean, especially in the winter, you know, but even in the summer, you just have to keep in mind that especially little old people, you can really drop their temperature. I think that's a valid point, something to consider.
I mean, I can tell you this, go jump in 70-degree water and swim a couple of miles, see how
Yeah,
you feel.
right. That's a fair point. That's a fair point.
That's a lot.
Yeah, you're swimming a couple miles in A water. I'm saluting you, man. Yeah. No, I think that's a fantastic point. Something to be mindful of. We sometimes lose sight of that, I think.
I that around here, and I get held back.
Yeah, it's just because it's different, right? People are like, we don't do that. I mean, just because, you know, there's probably lots of things we should do, right? We have blanket warmers. We give people warm blankets all the time. Why wouldn't we give them warm fluids, you know? I think it's a more humane thing to do. Yeah, I think it's reasonable for sure.
I've noticed when you've talked, you're not a big one to give a push dose of most medications. You like them to go in slow IV over a period of time.
Yeah, so I would say that's fair. I think almost every medicine I give, short of, and we'll talk about adenosine here in just a second. Almost every medicine I give, I just give it through the highest port on the IV and then just let it kind of dilute in. There's really nothing that is a good idea to slam in. And we sometimes, especially pre-hospital, we just get in a hurry and you find yourself just, you know, blasting stuff in. Ketamine, you definitely don't want to do that because if you give ketamine too fast, people don't want to breathe, especially the induction ketamine. So I always give that over a minute so that, because one of the benefits is that people breathe while you're getting ready to paralyze them, as opposed to etomidate where, you know, they'll often stop breathing. So I think if you can give stuff a little slower, it's, you know, you're probably better off. Having said that, do you guys still do that mumbo jumbo with the adenosine, like the stopcock and all that? You know that's complete horseshit, right? Like the giving it like through 2 stopcocks and like doing the like Indy race car thing. Like there's no evidence for that, right? There was a pretty good study done in Korea that says you just put the adenosine in a flush and just push it in rapidly and it works just the same. And all that crazy stuff of hooking it up to stopcock and push this one, then turn it over, push that one, and then push this one, and then stand your head and look to the west and push this one, and that, like, there's no, like, it just entertains us. It's no, you know, and the stuff squirting all over the place and all the disasters we've all seen with that, like, there's no benefit to that. It works just as well if you just put it in a flush and, yeah, just give it rapidly, you know, through a bigger vein, that all the 2 stopcock, 2 syringes, all that. It's a pretty good Korean study where they looked at it and they were like, yeah. So.
What do you think of D10 versus D50?
I think it's probably better. D50 is terrible on your veins, just terrible. So, and that's the other thing, especially D50. Like it doesn't expire if you don't give it in 20 seconds or less, right? Give it much slower. It is terrible on your veins. So, yeah, I think D10 is probably better, or squirt it into a bag of, you know, D5 or whatever, and just, because we're not building cabinets, right? You know, we're just giving them sugar. So on that thought, the dose, an easy way to remember, like I'm guessing, like if I ask you, you have a 4-year-old who's seizing and has a blood sugar of 20, how much dextrose do they get? Is it D10, is it D25, or is it D50, and how much? Like, no friggin' idea. Like, everybody wants to shut down their leg when you ask them that question, right? Because it's like there's too many choices.
It's a 4-year-old, D25, half.
Half.
You don't carry D25.
You carry. For peaks, you don't carry them more?
We do.
Yeah,
Yeah, we have E25.
yeah. You can have
Okay,
two,
we
so
don't.
yeah.
We got D50, D10.
But your first line is seizure stopping, so we're gonna get percent first.
So let me give you a simple dosing. For dextrose, it's 50 mgs per kg for everybody. And then you just dilute it. So 50 milligrams per kilogram is the dose of dextrose for all comers. And then you just dilute it. So you just look at what do they weigh and do the calculation, and then look at how much you have, and then just dilute it. And it's fine.
Like our protocol for adults is what, 175 to 250? No, 175 to 250 mLs of D10.
Honestly, I just do it until they come back.
Right.
You just have to know what the concentration is. So, and then let's talk about seizures for a second. You walk up somebody's season, what's your first line?
Well,
Okay. No, it's not a trick question. We're going right to the benzos here. Yeah. Okay. What's the dose?
5.
Of?
Well, it depends on the way you're giving it, right? So, intranasal, 2.5 each nostril, intramuscular, 5 to 10. And then, honestly, it's just one of those things where we're just.
Anybody else? What do the firewhackers do? Let's hear from the biochemist.
I'm not a medic.
They don't carry narcs.
Oh, you guys carry Narcan though, don't you?
We don't get to push it 5. Cops do it for us.
Right, that's right.
You know, he says 5 in the nasal, 5, initially.
Okay, so there's new guidelines out now, right? The Neurocritical Care Society has come out with guidelines. So what the problem has always been is we have this false perception that we don't want to give too much benzo up front because they're going to become apneic, right? That's what we know is that's complete horseshit. They are at more risk of becoming apneic from prolonged seizures than they are from too much benzo.
So with 10, because I used to give 10 at Jackson. I came from Jackson. When I got here, they moved me to 5, and I get 5 for protocol. Would it be better? Do you think 10 would be
Yes,
better on the initial?
yes, absolutely. The evidence is very clear.
Now, I have heard, like I said, one thing I also heard, this is just like I said, hearsay. I trust the person that told me that he preferred giving it nasal over than IM.
I think IM is better. The Rampart trial was pretty clear that IM is better.
His thing was that it was more, it was like higher, he wanted to do a higher dosage with a slower reaction is what he was thinking for.
Yeah. So we just did a podcast, just recently, just came out, a couple weeks ago, where we talked about benzos and seizures and all the different dosing strategies. We go into it pretty in depth with a clinical pharmacist from West Virginia. But we know that the longer a seizure continues because of GABA inhibition, the harder it is to stop it. So the more we dick around and not giving the right dose of benzo, the harder it is to stop it.
So we just want to murder the seizure.
Yes,
Okay.
that's right. Absolutely.
I called the doctor one time to get more Versed, and I was told, no. Do you plan on intubating them?
Yeah, they don't know. I mean, they don't read the literature
So
either.
what's the threshold, right? So if we get 10 and they're still seizing, should we just jump to ketamine?
Yes.
Okay.
So, so my recommendation for seizures is 10 of Versed IM. Hi, how you doing? Still, are you seasoned? Shagunk. And that stops the seizure. Ativan, it's 4 milligrams up front. Most places, people will get diarrhea over giving more than 2 of Ativan, but then they wait 5 minutes to give another 2. Just give the 4 up front and stop the seizure, for God's sake. They're way more danger of seizing longer by not treating it appropriately to start with. So 10 IM. And think about how fast you can give 10 of IM Versed. I mean, pretty damn quick, right? By the time you're dicking around with an IV, Just give them 10 of iambercin. And then the evidence is pretty good for ketamine as being the second line agent. But if you want to read the guidelines of the Neurocritical Care Society has guidelines on the treatment of status epilepticus, and it's pretty clear.
What's the dosage for that for the ketamine?
Ketamine is a dissociative dose, so 1 mg per kg. Yeah. Now, once you start getting up to, if you've given 10 of Versed and then you give them, 150 or whatever they weigh of ketamine, now you're getting to the point where you're going to have to watch their airway pretty closely. And I mean, I think there's a reasonable chance people like that, you can manage them with an oral airway and positioning, because it's not going to last that long. Because if you paralyze them and intubate them, now you've made the evaluation of their seizure more complicated. So if you can avoid that, I think it's reasonable. And put them on capnography, and you can watch their respiratory pattern, and you know exactly where you're at. I mean, anybody ever seen the colonoscopy? I mean, they're shoving a garden hose up your ass. They give you drugs and keep your airway positioned and open, right? They're not intubating you for that. So, I mean, we should be able to get away with not intubating people in status, just with airway positioning.
Would you also push that dose over 1 minute?
Yes, absolutely. Absolutely. Yeah, for sure.
Ketamine?
Yeah, for sure. And if you have, I don't know, what concentration of ketamine do you guys carry?
510.
Yeah, so it's 50 per ml. So you're going to have to mix that with a flush, right? Squirt it in a flush, because you're trying to give 2 cc's over a minute, and then you're going to leave half of it behind in the injection port. So just squirt it in a flush, and it's much easier to give it over a minute that way. So yeah, so seizures is a big thing. We think, did anybody bring the seizure guy from yesterday? Was anybody on that? No? Guys brought us a seizure dude who was seasoned to beat the band. He took a whole bunch of, got a whole bunch of benzos and didn't want to breathe, and he signed it out AMA last night. So that's the deal with seizures. And then propofol is the next, the third line for status. But yeah, I went to ResusX, which was a big resuscitation conference in Philly, and the neurocritical care doc that was there was like very animated and very outspoken about under-treating seizures with benzos. It's like, I don't know what emergency medicine people are doing, but you got to stop giving these, pediatric doses of benzodiazepines. She was like very adamant that seizures become very difficult to stop, or every minute, they continue.
I'm waiting on some of those lectures at the YouTube. I saw Mike's was on there.
Oh yeah.
So why does it seem like it takes so long to get the mindset changed throughout the system?
Well, that's the $1 million question, isn't it? Yeah, right. I wish I could answer that. I think part of the problem is that often medical providers are terrible about, when they get out of school, they're like, man, I'm glad I don't have to study anymore. I'm glad that shit's over with, right? They don't stay current on the literature. That's the first problem. And then the second problem is, same reason the fire service is so backwards. 200 years of tradition unimpeded by progress. I mean, look at how much better our turnout gear is, look how much better our equipment is, look how much better everything we have is, and we're still killing the same amount of guys every year. We just get further inside the building now. We have this, when I started, we had long coats and long boots. And, we just get people further in the building now. It's like 4-wheel drive trucks. You just get stuck further off the road. We have guys just get further in, and now they can't get out. Medicine is the same way. We just don't, people don't want to change things. It's hard to get people to do new things. And now that I'm an old guy, I find myself kind of stuck in my old ways. I can't remember, I was arguing with somebody about something, about why something was dumb, and they said, you just think it's dumb because you're old. And then I was like, might be right about that. So if you come up with, you made some good points. If you come up with an answer to that question, you could patent it and bottle it and sell it. I don't know why.
It just seems so why do you get certain experts that preach this is better,
Yeah.
and it just seems so.
But we still keep doing it the old way.
So hard to change.
Yeah, K-Exolate is a drug that we give for hyperkalemia. It's you can shove it up your ass, and that gets rid of potassium. Or they put it down your NG tube. And we've known for 10 years that it's harmful, but we just keep giving it. We just keep giving it because we've always done it, you know? There's a lot of things. Why are we doing CPR in traumatic arrest? I mean, that's another one. It's so obviously not effective, right? The heart is empty. Why do we keep smashing on the heart when it's empty? And then we're giving epinephrine. Why are we giving epinephrine to a heart with no blood in it? But we just keep doing it, right? Because we've always done it. So it's, I have a, you know what, actually this would be, I'll leave you with this. There was a qualitative study done in Australia. They took a 2-level cage with the center staircase goes up the middle, and they put 4 silverback gorillas in it. All dominant gorillas. And when they let them in the cage, they all went to 4 corners of the cage, and each one of them sat and watched the other one. They took 4 giant bunches of bananas and put it on the top level of the cage. And the gorillas are all staring at each other, kind of like firemen would, you know, they're all staring at each other like, who's gonna go up and get those bananas? After like 2 hours, one of the gorillas is like, fuck it, I'm in. And he goes over to that staircase. As soon as he goes to head up the staircase, they turned a fire hose on him and blasted him with water and knocked him back down the stairs. So he, you know, dried himself off, went over and sat in the corner. Over the next period of time, 24 hours, each of the gorillas then would try to go up those stairs to get the bananas. He'd get blasted with the fire hose. They did that for 2 days. Finally, the gorillas are like, I don't need the bananas that bad, screw it. They then took out, one at a time, they replaced one of the gorillas with another gorilla. When the new gorilla would go, realize the bananas are up there, and he'd go up the staircase, the other gorillas would jump on him and pull him down the stairs. Like, hey man, you're gonna get blasted with that fire hose, don't do it. Eventually they replaced all 4 gorillas with new gorillas that have never been sprayed with the water. And they continued to jump on the gorilla, the new gorilla, and keep him from going up to get the bananas. Those gorillas had never had that noxious stimulus, but they continued to jump on the new gorilla and pull him down the stairs. Under the, because we always done it that way, clause. We have people that continue to do things and they have no idea why they're doing it other than somebody else told them, that's just the way we do it here. And medicine is the same way.
I think a lot of it also is legality of it. Like when we have it in our protocols that we're supposed to do CPR on a traumatic arrest, and you may want to change it, but it's going to take upper echelon to change it, and then upper echelon's going to have to make the decision, yeah, I'm changing it, and not take on the liability of any legal factor that's going to come after it, because some lawyer's going to try to, I think that's a lot of it too, is just the legality of it, of worry about legal fallout.
That you see it on TV. What TV does it in real.
It's so what do you guys have for, like, how do you do protocol review? Like, how do you, like, what's the policy, or how do you, what's the process for how you change things?
So we have a protocol and any changes that, we typically do it yearly. Protocol team usually starts in January, and by March, the medical director will review like the changes that we made or proposed protocols, and if he likes them, they'll move forward, and if not, they won't. And typically that comes with doing research and attaching studies to the proposed changes, and it's just up to the doc at that point whether they want to accept and move forward or not.
So I think the key is, right, you have to do your homework, you know, and you query, you know, the top 5 trauma centers, and then you ask, is this the best practice? You know, do you guys do finger thoracostomies?
Not yet, no. Jennings does, my part-time job does, but not yet.
So, you know, the evidence is pretty good for that. But I think the first step is, I think Chris is a reasonable guy. who's certainly a good guy. I think every interaction I've ever had with him, he always wants to do the right thing for the patient. So if you look at, present the evidence, say, hey, these 12 trauma centers and these systems have all stopped doing CPR. Why are we doing CPR in somebody with an empty heart, and just get, his opinion on it,
So if we're not going to do CPR on a traumatic arrest patient, how would you, would we just not even attempt resuscitation, or would we do other interventions prior to attempting resuscitation?
So you have to have a protocol. So our protocol is you encounter a patient in traumatic arrest. Step number one, do they have injuries incompatible with life?
Right.
If they do, then we obviously do not resuscitate them. If they do not, then we immediately, EMT throws in the eye gel. Paramedic, we will start CPR and we'll get the ultrasound probe out. We'll look for a lung slide. Within stop compressions, look for a lung slide. Do they have lung slide on both sides? If they do, then we know they don't have a tension pneumothorax. We go to the heart. Do they have wall motion? If they don't have wall motion and they don't have cardiac tamponade, then we're done. If they have wall motion, but they don't have cardiac tamponade, then we dump the cooler in them and we start CPR, because now we're circulating the blood that we're giving them. If they have tamponade, then we put a needle in their pericardium. And that's the way we proceed. If they don't have lung slide, we vent both sides of their chest and then look for a lung slide. So it's about a 2-minute process, and then we have an approach, and everybody knows it. We train everybody on it, and everybody does it the very same way. So that's the the sequence of events. Because if they don't have tamponade and they don't have tension pneumothorax, they're dead, right? If they have wall motion, many of those people are just so hypotensive that they have a pulse, we just can't feel it. So when you see wall motion, now you dump the cooler on them and you try to give them something to circulate. But you got to have a plan for getting them somewhere where they can, do damage control resuscitation.
Have you guys had many successful resuscitations with that protocol yet?
No, we haven't had any. We've had all dead people.
Okay.
We've had all dead people. We've had people that we probably would have resuscitated and probably would have called a helicopter and done all kinds of futile therapies, but we looked at them. They have lung slides, so we know their lungs are up. They don't have tamponade, and they're dead. We did have, like 3 months after we initiated it, Matt Morrow, who's the chief at Let's now, he had a guy who was ejected from a car. He did not have lung slide on one side. He vented his chest, and the guy got a pulse. The guy had a stronger pulse back. He took off for the landing zone, and the guy lost his pulse again. He ultrasounded his heart. He had tamponade. He put a needle in there, got like 15 cc's off. The guy got a pulse back, dumped the cooler, and then the guy arrested again. And they canceled the helicopter and just pronounced him. So, he was a young guy with catastrophic injuries. Huh?
So the mortality rate on
Yeah.
traumatic arrest is
Especially blunt trauma. Yeah, especially blunt trauma. Blunt trauma is even higher than penetrating. I had one, I don't know if any of you guys were on it, I opened a guy's chest in the ER that got shot here on like New Year's Eve one time. We got a pulse back transiently, and then this was a few years ago, 4 years ago.
I would follow.
But yeah. Well, all right. Well, this is my gift to you. You're out 20 minutes early. I'm happy to answer other questions. Anybody wants to talk about that IO thing, I'm happy to go over that. In the interest of never seeing a tibial plateau IO come in again. Nothing says I've given up on life.